Everybody, and welcome to the Fluid and Electrolyte workshop organized by West Bengal Academy of Pediatrics. This is our third and the final day. At the end, there will be a quiz competition, and you must compete. And there are attractive cash prizes also. So today, our first speaker is Dr. Sumantra Sarkar. He is MD Pediatrics and DM Pediatric Nephrology AIMS. And he is the pediatric nephrologist and assistant professor at Department of Nephrology, North Bengal Medical College. And he has got multiple publications. So he will take the next session. So over to you, Sumantra.
Thank you, sir. And a very good evening to all the delegates for today's program. Today is the last day of our WAP, this effort of this CME. Huge successful CME, and as a legacy of the previous 2 days, we have multiple interesting sessions today. So without wasting my time, I am directly going to my slides, and hope my slides are visible in full screen and I am well audible. Yes. I request once more to the participants, if you have any doubts or queries, you put it in the chat box. We'll try to answer them at the end of the sessions. And if not possible to answer on live, we'll write it or we'll write in the WhatsApp group. Better not to put in the QA session because we are trying to collect it from a single pocket. So at the outset, I thanks to our WAP team, Sapon sir, Mehish sir, Atanu sir, for giving us this optimum platform to the newer bloods. So today my topic is dysarthemia in hospitalized children, a much more commonly faced problem in our day-to-day practice in either OPD, IPD, or in our office practice. So our outline will be basically from the osmolality and tonicity, a brick concept, which has already been taught in day 1 and day 2 also. Different electrolyte homeostasis, how the sodium is maintained, hyponatremia, and the final key message. So I will try to stick my time within next 25 minutes. And Sapon, please remind me if I go a little bit fast. So are we run by slides? Not all the points may be required. So only the highlights are required. So that's why some slides may be moved fast. This is only the recapitulation of the previous 2 days because total 10 sessions has already happened. So just a minute of recap. That total body water is 60% of the total body weight. Among them, intracellular water is just 40% and 20% is the extracellular water. And among them, extracellular water, interstitial fluid, plasma, and the transcellular fluid is there. And what do we mean by transcellular fluid? That is the basically which fluid is very minimal amount in physiology, just like pleural fluid or peritoneal fluid, and they get excess during a pathology, or the fluid in the eyes or in the CSF. So regarding the body components, as the child grows from newborn to adults, the body fluids amount gradually percentage get decrease, and the cutoff is mainly on the extracellular fluid amount of cutoff. Intracellular fluids remains more or less same throughout from infancy to the adulthood. And now coming to the main ECF cations is sodium, so that's why our topic is more important, that one. And good to know that the main intracellular cation is potassium. Similarly, the main extracellular anion is phosphate, and the main extracellular anion is the chloride. So sodium determines the ECF volume such. So to make this little bit difficult and maybe a boring topic little bit interesting, I need the help of our attendees also. So can we start with some good case discussion? And so suppose a 10-year child with chronic kidney disease with diarrhea, the serum urea is 312 and the serum sodium is 131. So can I ask my attendees to help me on this one, which is a correct statement? The osmolality and tonicity both is high for this child. The osmolality is high, but tonicity is low. The reverse, the tonicity is high, but the osmolality is low. Otherwise, both the osmolality and tonicity both are low. Which is the correct option? I may spare 10 seconds for this one. I will just check on the chat box. You can answer just A, B, C, or D if you wish. And then after 10 seconds, we can move to further one. Okay, so now better we move. Yeah, most of them are in a right tone. So what is the difference between osmolality and tonicity? This is a simple example of this one. Osmolality basically means a solution which has some solutes, and all the total solutes confers the osmolality. Remember the unit, it is in milliosmol per kilogram, but not necessary. This is irrespective of the property of the solutes which is crossing a particular membrane, yes or no, or with difficulty. Wherever tonicity means only the effective osmolality. Suppose some of the components like sodium, urea, glucose, any component which is present in the solution creates an osmolarity, but not an effective osmolarity. Whichever components will have a respect to a membrane, suppose it has difficulty to cross the membrane, will convert to the tonicity only. So they are the effective osmolarity, just like sodium, and in the presence of normal insulin, the glucose becomes the effective osmol. So urea is not, because it can freely permeate from throughout the cell membrane. So here the in CKD patient, though the urea is sky high, the osmolarity may be very high, but tonicity will not increase. On the reverse, the tonicity is going to be lower one because the sodium is decreased. So here the osmolarity will be, we'll come to the answer also. And remember the third word we sometimes encounter in a clinical word, that is osmolarity. Here it is more or less similar. We don't need to bother on this entity only. This is the unit is in milliosmol per liter. The values are more or less same, maybe a bit less than the osmolarity. And this osmolarity value can change with the temperature of the solution also. Most likely not that clinically important in our day-to-day life. What we need to focus is on the osmolarity, milliosmol per kg, and the effective osmolarity, that is the tonicity. Because day one, Nisar also told about the characteristics of normal saline and 5% dextrose, which is isoosmolar, but hypotonic like this only. So here it's come to the solution. So here osmolarity we can measure by a machine that is called osmometer. That is a measured osmolarity, or we can calculate in our by taking the sodium, glucose, and urea value. So the calculation becomes easy. That is 2 into sodium plus glucose plus BUN in millimole per liter. Or if you don't have the value in millimole, that is 2 in sodium plus glucose by 18 plus blood urea nitrogen by 3. So here we can see that the osmolarity here will be very high for this child because his urea is very high. Remember, this one means suppose the patient has a urea of 40, the BUN will become approximately 20, half of the value of urea. And why it is 2 into sodium? Sodium is a monovalent ion, but still it is having a 2 multiplication. That's because sodium doesn't come alone. It comes with some of the like chloride or something that also equally converts the osmolarity. So osmolarity 2 into sodium is sodium plus something, that is chloride, and plus glucose by 18. And the tonicity will be deleting the urea. Only the sodium and glucose will maintain the tonicity. So here, this is the osmometer, which we can calculate the measure the osmolarity directly. And many times it's possible that the child is treated in mannitol or something else. The measured osmolarity is 310 or 320, but the calculated osmolarity with this sodium, glucose, and BUN will be lesser, that is 280 or something. That is called a osmolarity gap. So for this patient, so we know the answer is B, that is osmolarity will be high because of high amount of urea, but the tonicity is low because urea does not convert to any tonicity, and the sodium is less than the normal, less than 135. Okay. So now coming to the electrolyte balance, our body is in a tight balance of the sodium, potassium, and other electrolytes, and mostly kidney becomes the key organ playing role in maintaining this balance. So why sodium is so important? Our body tries to keep it in a strict value between 135 to 145 millimole per liter. And most of the time, we usually refers to as serum sodium or serum potassium, but plasma sodium and plasma potassium should be the ideal terminology if it is measured on that way. So regarding this sodium, the incidence of this dysnatremia, either hyponatremia or hypernatremia, is not that uncommon. That we have already faced by, in fact, by our interns, house staff, residents, and as well as the practitioners. Day-to-day life, we face dysnatremia of some degree, may not be clinically much relevant. So it varies from 10 to 20% as per different studies, depending on which type of patient are being selected for the study. And the highest number is probably shown by some Italian group in a pneumonia study by an ICU, that is up to a tune of 45%. So usually we interchangeably use serum versus plasma, but there is some difference. I will come to the next slide. And regarding hyponatremia, that is low sodium, whichever the value drops below 135, it is hyponatremia. There is some degree, mild, moderate, and severe. And remember the word between 120 to 130 is the moderate, above it is mild, and below it is severe. Why it is important? Because the treatment will vary as per mild, moderate, or severe degree. And there is also an entity regarding hyponatremia. Is this happening over a period of 2 days or more than 2 days? It will also depend. It will also change our treatment in due course. That's why it is important to know throughout which duration the hyponatremia is running through. Regarding the sodium control, the main key organ, though this is a busy slide, I will not waste my time much here. Though this is important, you can get it through any textbook. The key control is from the RAS system, renin, angiotensin, aldosterone system. And in a nutshell, it comes, the theory starts from the angiotensin that comes from liver. This is converted to angiotensin 1 by renin, which is secreted from kidney JG cells. The angiotensin 1 again converted to angiotensin 2 by the lungs S enzyme, and that is a famous enzymes which have become more famous during these COVID times by all the heroic and adverse events were done by this ACE. And this angiotensin 2 has direct property to stimulate the aldosterone, which causes active sodium and water retention. But this also has an extra direct action on the tubules. It can also increase the vasoconstriction, particularly the arterial vasoconstriction. It can causes the sympathetic tone, and moreover, it can also stimulate the secretion of ADH, which will only cause retention of free water and not sodium. And that's not in the DCT, but in the CD, in the collecting duct, and that has also been explained by Dr. Niladri yesterday. So coming to our next case, so we can expect some more interaction with our colleagues or with our attendees, that which is the primary disorder of a sodium loss or a sodium gain. It's a hyponatremia, it's hypernatremia, is it a hypovolemia, or it's all three? So we can wait another 10 seconds on this one before I move on to my next slides. And just any answer? Yeah, its answer is coming. The first answer is a perfect answer. Huge. Okay. Any more? Oh, yeah, perfect. Good one. Okay, so now we skip. So coming to the details, hyponatremia and hyponatremia are basically not primarily a sodium disorder. It is basically our body or the kidney has a huge buffering system to manage whatever sodium less or more we intake, whatever water more or less we intake. We can adjust this as per our excretion or some tubular function to manage that in a more or less normal osmolarity, normal tonicity, and normal sodium levels. But wherever our kidneys are at fault or the intake or the excretion is abnormally high, that time these disorders occurs. And hyponatremia or hypernatremia are basically disorders of water and not primary sodium. So hyponatremia means is excess water. Maybe both we are losing sodium also, we are losing water also, but the sodium loss is much more than the water loss. So that's why there is a hyponatremia, and the just reverse in case of hypernatremia. Whereas hypovolemia is basically targeted of a sodium disorder. Here also, in case of hypovolemia and edema or hypervolemia, there is either too little sodium. So in case of edema, there can be possible that sodium is also retained, water is also retained, but there can be either differentiation of the sodium and water retention difference. There can be hypernatremic edema or hyponatremic edema. Okay, so basically hyponatremia or hypernatremia are not disorders of sodium, they are disorders of water. So hypovolemia is a disorder of sodium only. But remember here, little bit confusion may be created that in case of hyponatremia, though there is a too much water, we don't see much of the time the edema, because most of the time the edema is very much clinically silent, and many times it also equilibrates within the IC compartment and the EC compartment. It goes into the intercellular compartments and edema doesn't happen. And similarly, things happens in case of hypernatremia, where there is edema with sodium retention, but the sodium edema with sodium retention, but always not all the edema does not cause hypernatremia. Suppose in case of nephrotic also, just because here the sodium easily passes through the extracellular space to the intercellular space in due course. That's why. So this is one of the pictorial depiction. So whenever we get a hyponatremia, as I already told, if we take increased amount of salt, we can we don't have directly hyponatremia, because our body can manage somehow the excretion of sodium. It will excrete the water less and make a balance. So that's why whenever there is a huge loss of water and sodium, suppose in the picture we can see a child is having a diarrhea, he's losing huge amount of sodium in this first picture, huge amount of sodium as well as water from his GI tract, and there is a hyponatremia and hypovolemia also. There is a hypovolemia, not now there is a isonatremic. But whenever the child is not taking an ORS but only plain water, here the volume may be more or less restored, but sodium is not restored at all. So it will lead to an hyponatremia, and that's why a dehydration also. So like this, so whenever there is some hyponatremia, sometimes ADH is playing a role. How so? That can be a directly inappropriate ADH, like SIDH, that happens can in case of pneumonia or meningitis, that is already discussed in previous test class, or maybe indirect ADH phenomena, just like in case of, suppose a child is having a diarrhea, so the intravascular volumes goes low, the tonicity goes low, the volume goes low, all our RAS system get activated, our ADH system parallelly get activated. And when our RAS is activated, huge amount of sodium and water retention from the distal tubule, and when our ADH get activated, huge amount of free water retention from the collecting duct. So if ADH get activated by any diarrhea, vomiting, or any pain or any other stimulus, it will create a huge amount of free fluid retention and leading to hyponatremia. So a little word on pseudo hyponatremia also. this thing you can face in case of some pediatric patients, just like a case of steroid-resistant nephrotic syndrome. Here, what happens where we are talking about the plasma and the serum sodium level estimation, how the sodium is been estimated mostly by the enzymatic method in most of the labs in India, but a little bit high quality lab does it through a ion selective electron method. That can be indirect or direct. Most high-end lab does it through a direct ion selective method. What is the difference? Because suppose a child is having, suppose this child A in the picture in the left side is having a hemoglobin of 14 or 15 and a paxil volume of 40%. And this red color, this gray color is his normal lipid content. So this is around 100 of cholesterol conferring 2% of the plasma volume. And the yellow content is the plasma volume. That is around 60% or 65%. And this yellow and gray color combination is called the serum. Okay. So now this child, if it is a steroid-resistant nephrotic syndrome who is having persistently cholesterol of 1000 even without drug, now this lipid bar has been 10 times increased, but the plasma has dropped proportionately, and he has lost his sodium also proportionately, but the serum remains constant. The serum is the gray zone plus yellow zone. So if you compare this green color dot as sodium, the sodium and yellow ratio has not changed. So yellow is the plasma. So plasma sodium has not changed. In the first baby, it is 150 millimole per liter. In the second baby also, the plasma has dropped, the sodium has dropped, and the ratio remain constant. This is also 150 per liter. But if you consider the whole serum, here the serum sodium has dropped from 150 to 100. This is just a theoretical case scenario. So remember, if we do a plasma sodium by selective ion selective direct method, it will show us, even if in hypercholesterol state, it will show us a real sodium picture of 150. But if you do in a more common labs, we are doing the indirect method, it will come little bit low. So this is the cause of pseudo hyponatremia. In case of pediatrics, we face most commonly in case of either giving a TPN or in case of nephrotic, where lipids causes the problem. In adults, there can be some protein increase or paraproteinemia or multiple myeloma can happen. So some previous attendees are asking regarding this ABG machine sodium also. So regarding this measurement by ABG, most of them are done by this ion selective method only. So we presume this to be more accurate result than a standard lab of enzymatic method. But problem is that for that ABG machine, we need to recheck the machine, recalibrate the machine each and every time, preferably maybe every 1 to 2 days interval as per the company selection. Otherwise, the reports are non-reliable because ABG reports come faster and lab reports, most of the lab comes a little bit late. So as a point of care, if you need to check the sodium in case of treatment of hyponatremia or treatment of hyponatremia, you can go through a ABG reading or a lab reading also. ABG reading will come faster. And if your machine is well calibrated, you can well rely on it. And if you are checking the trend many a times, so that trend becomes much more easy even if your calibration is some little bit improper. So now coming to the reasons and causes of hyponatremia, this is also a busy slide, sorry for this, but I will only go through the key options. So this hyponatremia is associated either with a isoosmolar, hypoosmolar scenario. So isoosmolar means, just as I talked, in case of pseudohyponatremia or in case of some diabetic or decay where the glucose is sky high 500 or 600, and to maintain the same 300 milliosmol of osmolarity, the body tries to decrease the sodium, so the osmolarity remains constant. So in this case, they are isoosmolar and hyponatremic. But most of the common scenario we face is the middle one, the hypoosmolar hyponatremia. Here, what happens that this type of child can come with euvolemic status. If they are losing huge amount of sodium and water in same amount, they can come as hypovolemic. If they have lost the sodium and water, didn't replace the water well, or maybe hypervolemic even, because they have gained some water but no gain of sodium, it will cause to hypervolemic hyponatremia. The common example for hypervolemic hyponatremia are either cardiac failure or in case of cirrhosis, and rarely in case of nephrotic who are in a overfill situation, which Professor Bagga has taught on day 1. So though this is a rare phenomenon for overfill, mostly they are in an underfill condition. And regarding euvolemia, we need to know that we are losing sodium and water in same amount through kidney or not through kidney. That we can see by the urine osmolarity. If your urine osmolarity is high, that means we are losing it through the kidney. If the urine osmolarity is not high, that means probably we are getting more water intake. That's why the same amount of water is getting excreted through the urine. Probably the primary polydipsia of day 1 and day 2, because we all know that primary polydipsia is basically example of hypernatremia and a differential diagnosis of diabetes insipidus and not an SIDS type of diagnosis. So this is only possible on the initial days of primary polydipsia only. Whenever people just started taking huge amount of water on first day or second day, and the urine is diluted and the sodium drops. Later on, the body compensates. And regarding hypovolemic hyponatremia, again, the loss can be through kidney, like in case of RTA or use of Lasix, or that can be not through kidney, like burn injury, through losses to skin, or due to some diarrhea losses to the GI tract. So why this important to know? Because the treatment will vary. Where we'll give sodium, where we'll give only water, where we'll give sodium and water equal amount, that will vary as per the scenarios. So most of the hyponatremia in our world is probably iatrogenic. Previous decade which we are doing, giving a half DNS to all pediatric age group, and maybe isolate P to the higher range of infants also, the bigger infants also. We currently know that this is now condemned, so that's why that has created huge amount of iatrogenic hyponatremia, because most of them are sick child and their ADH are very high. So whatever we give, they will retain the water and they will excrete the sodium, leading to hyponatremia. So that's why it is already discussed, just a repetition. But as some attendees are still asking question in the WhatsApp, the current choice for maintenance fluid in newborn is ISOP, that is N/5D5. And for any pediatric age group, it is half DNS, it is full DNS and not the half DNS. But it is for only the day one fluid, because on day 2, day 3 onwards, you already have a sodium, potassium, and everything in your hand, and you have to titrate your fluid as per their reports. And also, this is not a dogmatic of the day 30 situation, because day 29 baby and day 31 baby are not that much easily different. So while taking a decision regarding a peri 30 days decision, you apply your clinical sense to make the fluid either a ISOP or maybe N/3 or N/4 or whatever may be. But try to come as the child goes older to start with a DNS. So coming to the clinical features of hyponatremia, either it can be acute one less than 48 hours. So the symptoms are more specific, that is lethargy, obtundration, and in severe case can have seizure also. And for chronic one, the symptoms are much more subtle, and there is plenty of options that we can miss these symptoms most oftenly. And regarding the signs of dehydration or the signs of hyponatremia, that signs can be as per which compartment is being lost. If the plasma is lost, there will be maybe a low BP, postural hypotension, or the CRT is prolonged. If the interstitial fluid is lost, there can be a skin tenting that we used to see the dehydration in case of diarrhea child. And the transcellular fluid is lost. As I told, transcellular fluid means in the orbit or in the CSF. So there can be depressed of fontanelli or sunken eyes. So this is on the right side picture shows on one more important thing, that is in case of the third space or the interstitial space, if the fluid goes up, that is called a edema. If the fluid goes down, that's called the dehydration. Similarly, in case of second space, just like an intravascular space, if the fluid goes up, it is called heart failure. If the fluid goes down, it is called hypovolemia. So these four terminology not to be intermingled, because edema and dehydration cannot happen in the same patient in the same time. And similarly, heart failure and hypovolemia cannot happen in the same patient in the same time. So some attendees have asked the question to Bagasar that a patient with hypovolemia with pulmonary edema. So probably this is a theoretical scenario. It is usually not possible unless the pulmonary edema is due to non-cardiogenic cause. That can be either inhalation gas or something like this, then it's okay. But CCF and hypovolemia cannot coexist. Edema and dehydration cannot coexist. But the important thing is edema and hypovolemia can coexist, and it usually do occurs in most of the cases of nephrotic child who are with severe edema and mostly admitted in our ward. So the classical example is severe edema with relapsed nephrotic syndrome. Fine. So coming to our next case, this is a 3-year-old boy. His pre-illness weight is 8 kilo. Luckily, we know the pre-illness case, because in most scenario of what happened to our day-to-day practice, we don't know the pre-illness weight. Anyway, so the child having a diarrhea with dehydration, and currently the current weight is 7.2. So what is the percentage of dehydration and how it's calculated? So we can go through some options. That is a 5% dehydration, that is a 10% dehydration, 15%, or a 20%. So again, we can wait for another 10 seconds and we can go through the options. Can I ask our participants to answer for this one? Either they can write the percentage or the options, A, B, C, D. Yeah, most of them are in correct line. The first answer, most of the time, the correct answer is coming correct. So, okay, somebody has asked the duration also. Anyway, the duration is either 2 days in less or 4 days in less. The percentage of dehydration will not change. The treatment will change, but percentage of dehydration remains same. Okay, so I will say also that this symptoms is for more than 48 hours. So, okay, then come to the answer. So, how the dehydration or the
5 minutes more, around 5 minutes.
Okay, sir. Okay, sir. Fine. So the dehydration part is calculated as per pre-weight illness minus illness weight during illness by pre-weight illness. So here 8 kilo minus 7.2 kilo, that is 800 gram by 8 kilogram, that is 10%. So it is coming under moderate to severe dehydration. So next, how this deficit fluid, what has been lost? The child has lost in diarrhea, maybe some free water only, maybe some free sodium only, and maybe sodium mixed with water only. So the three compartments has to be addressed well. So there can be a free water deficit, there can be excess sodium or excess electrolyte deficit, there can be a sodium plus water mix, that is solute fluid deficit. So how to calculate? Find the importance of 2 days versus more than 2 days, because whenever it is acute, only 80% of the ECF has been lost. If it is a chronic one, only due to acclimatization, only 60% of the ECF will be lost. So any dehydration calculation hyponatremia, we have to think about ongoing loss, already a deficit, and the maintenance. So suppose this is a 7-kilo child who is having a 4 days of diarrhea, he's 10% dehydrated, current 26.3, and he's having hyponatremia 125. A classical example of hyponatremic dehydration. Now, how to calculate fluid? So we can go through a laborious job that is already described in Harry Redland. You can go through it. So I am just keeping it. The maintenance fluid has already been taught in day 1, that is 7-kilo child, 700 ml water, and 3 milligram per kg of sodium. But for the deficit fluid, we have to calculate how much water sodium has been deficit. So that is already a 4 days illness. So 0.6 from the extracellular fluid into the body weight 7 kilo into the normal standard sodium. And what is the excess sodium loss? We will come into the left side. That is the ideal sodium 135 by the existing sodium 125 into 0.6 is the constant. It is this 0.6 is not as per acute or chronic, because here 0.6 is the total body fluid which contains sodium, that is 60%. So we can go through this laborious calculation, or we can have a short calculation that if the child is having a symptomatic hyponatremia and the sodium is less than 125, we need to correct it little bit fast. Little bit fast means never correct more than 10 to 12 per 24 hours. Or if you have a good rapid report coming facility in your hospital, then maybe 1 to 2 per hourly. So you can start with a 3% saline to treat this type of children. But if you are facing a SID like problem, and it is not an urgent scenario, you can always go through a water restriction of less than 2/3 of water restriction. For AKI child, it is again a more problem. That is, in case of AKI, many a times it is possible not to restrict water. So hyponatremia and hypernatremia, which is not medically treated, can be well treated by RRT. So our treatment goes like this. So coming to the next last scenario, this nephrotic with hyponatremia we are skipping for the time being. We are coming to the hypernatremic situation. Whenever extra salt we take, we doesn't face the hypernatremia because our body has the capability to excrete the sodium. But when the excretion is not proper, there hypernatremia can occur with hypovolemia or with hypervolemia or with isovolemia. So the standard example of hypervolemia, if somebody is giving 3% saline to a patient for raised ICP. The standard example of hypovolemia is if somebody is losing a water in a diarrhea and is giving a improperly prepared ORS. ORS is mixed with 300 ml of water and more sodium is gone. So this is a child of 7 kilos, same child, 10% dehydrated, 4 days illness, and 160 is the sodium. He's having a hypernatremic dehydration. Here the calculation is through Harry Redland is again a bit difficult. Ideally, we should go through this type of calculation only, particularly in tertiary level care. But many a times we also even do a relatively easy formula that we follow, that either 150% of the total required fluid, that is in the quality of either N/3 or N/4 or even lower. But even if the child is having a raised, even if the child is not getting well by this N/4, we can go lower up to N/5, N/6, but better not to give sodium free fluid in the fear of rapid drop. Always measure the sodium ideally every 12 hourly or at least 24 hourly, and don't expect a change of more than 10 in a day, either for hyponatremia or hypernatremia. Problem starts with the AKI patient, because when an AKI will have a sodium of 155, with the oliguric AKI, high fluid intake is not possible. That time we go drop more further with the sodium content of the fluid, N/6, N/7, and in dire situation, sometimes N/0, that is sodium free only dextrose fluid. And even if it is not corrected by that, it becomes an indication of dialysis again. So in case of DI, as Dr. Niladi told, we usually they are in dehydration, we don't give NS bolus, we give N/3, N/2 like this bolus. But if they are in shock, we need to give NS for resuscitation purpose only. So our take home message is we have to take care of the blood volume, tonicity, and serum sodium. They are in a tight balance by the body with our enough buffering power. But many a time it goes haywire. So dysnatremia for a child, either hypo or hypernatremia, calculate the volume status also, and then decide what to treat, how to treat. The treatment may vary from child to child. Try to stick with the protocols and formulas that are clearly given in Harry Redland. And if you are not, it is a little bit difficult, or the lab value is not that supportive, you can also, as the formula, which is much easier, I have shown you for the hyponatremia and hypernatremia both, you can follow them also. But always check your sodium every day and change your precision as per your sodium reports, the fluid amount and the fluid percentage. And by this, I am thanks to all my organizer for giving me the opportunity, and also I use this platform for welcoming into our next ISPN Con happening in just 1 week pre-puja. This is a national pediatric nephrology conference with a basket of international as well as national faculties. So I am stopping my slides here and I am handing over my mic. And again, I thank you to WAP team. So Sapun sir.
Thank you, Dr. Raut, for your excellent and wide coverage, because all the
I may be a
questions
little
that
bit
has
fast,
been
sir,
asked, you
but
tried to take up and try to explain. Just a few questions before we go to the next session. So it is from Dr. Tushita Lakeda. Sir, can you please explain why SEARD is said to have euvolemia, euvolemic hyponatremia, when there is a free water retention?
yeah, sir. Today day 3, so sir, that's why brilliant type of questions are coming. So mostly in case of SIADH, in most of the time of SIADH, the fluids, what I already told, that may shifts into the intracellular compartments. And whenever there is the intracellular edema, it is not an evident edema. So the volume, that is the volume in the second in the vessel space, they remain the constant. All the sodium and the water, whichever the water is excess, they shifts into the intracellular space. That's why the volume is normal for SIADH, mostly. Can we take 2-3 more questions, sir, or we can live online?
Yes. I'm searching for the questions. I'm searching for the questions, but no questions I can find.
Okay, fine.
So can you see any questions? I can see. I covered everything. No.
Okay, so in case of further question, we can solve in a.
There is no question.
Okay, sir, no problem. In further question, we can solve in typing. No issue. How hypervolume management from hyper.
So now, Dr. Shumantro, please conduct the next sessions. There are some questions now. Exclusive breastfed baby with hypernatremia and hypernatremic dehydration.
Must be Sujoy sir doing this question, because this question is floating from last 3 days. So, okay, sir. Basically, hypernatremia is not that common in case of newborn, but in case of tertiary center, as in our centers, we found many a time these babies coming with this. Mihi sir has already explained previous day that maybe a child is on phototherapy or in a excess heat position, so that's why losing a fluid. That's why they're having an hypernatremia. Or so many a times, not for exclusive breastfeeding, but what some of our surgical teams does, because of the increased weight gain, in spite of a normal milk or a breast milk, they give a high skim milk to the newborns or to the infants to have an increased weight gain. But parallelly, for the high sodium content, they usually have a sodium of 165, 170, 175 like this. So what we do at that time, we usually advise them to have that feed come to a normal milk feed, that is around either a breastfeed or a normal low skim milk feed, and along with some free water in the form of double diluted ORS. We advise them to make the ORS in a 2 liters of fluid. This is not an exact calculation, but it's an arbitrary calculation. But usually they do respond to this child, but we make a 12-hourly estimation of the blood sodium. But the problem is that we are filling the child's stomach with half ORS, so we are cutting the nutrition here. So we have to judge for that time period only for 3 to 4 days. But if this is a persistent one for the question as goes for exclusive breastfed child, we need to keep our eye open for a primary DI also, because DI can present in a newborn period also. But usually the RT and this type doesn't present in a newborn, but DI can present in newborn. So I hope I can partially at least satisfy the audience.
There is one question left. You can answer in the chat box.
Okay, sir. Okay, sir. So we can
now please conduct the next sessions, Dr. Raut.
Okay, so can I request our next speaker to share his screen? So our next speaker is going to be none other than our next topic is on disorders on potassium. And Dr. Saheli, are you on board?
Yes.
Okay, can you share your screen, please? So our next speaker is none other than Dr. Saheli Dasgupta. The topic is again an interesting one and a most commonly and a fatal one, which is day to day we encounter, because both hypokalemia as well as hyperkalemia can have a blunder in day to day life, and they will hardly give. Dr. Saheli, if you have any issue, I can move the slides for you also.
Saheli is from which college?
Shumantro, can you take the short introductions of Dr. Saheli?
Yes, ma'am. Yes, sir. Just doing, sir. So Dr. Saheli is from. Is my screen visible, sir? I'm not sure.
Yeah.
Nice.
Okay, then fine. So she is MD from MD Pediatrics. He has completed his pediatric critical care fellowship also, and currently she is working in Amri Mukundapur Hospital as an PICU associate consultant, and she is also attached with Apollo Clinics. And his main area of interest is cardiac critical care, asthma, ECMO, and ARDS. So over to you, Dr. Saheli. Can I stop my screen and you can share it?
Yes, yes. It's
Do
basically
you
I
having
can't
some glitches?
share. Yes, yes. I'm
No
having
issue.
some problem.
We can help you. We can help you.
It's not coming.
Otherwise, do you not mind if we move the slide for you? Is it
Really,
possible?
Dr. Sumantra can share the screen and you can just go on saying next. That would be helpful.
Yes.
We can. Otherwise, we can give you
Sumantra,
10 more
please share.
seconds.
Yes.
Acha, okay, sir.
Sumantra, please
Okay,
share.
sir. Okay, sir. Dr. Sally, are you comfortable for this one?
Yes, sir. But actually, my slides are not opening. I don't know why it's happening.
No issue.
No issue. No
Should
issue.
I-
Sumantra, please do it.
I don't know why.
First, if you, first,
Mantra, you
if
have the
present-
slide, or I can just.
Me too,
I
I will
mean,
have to do. I have also a slide, no issue, but you can do.
Yeah, actually, I have shared it with me, Dr. Mihir, sir. So, sir, please.
Okay,
just-
okay,
Okay, I'm
One thing you
sharing.
can do, Sayan, you can keep the slide presentation in the desktop, keep it in a open mode, and then you open it. Sometimes it may happen.
Is it visible?
Yeah.
Ah, it's
Yes.
fine. We can go to slide number 1.
Full screen. Yes.
It's visible, sir. It's visible.
Yeah. Perfect.
Dr. Sally, you can start.
Yes, yes, yes. Is it now visible now? Is it visible,
Yeah.
sir?
Yeah, we can
Yes.
see.
Okay, okay.
We can hear you. We can see the slides also.
The slides are not moving actually.
So slide will be moved by Dr. Mihir Sarkar. We are
Okay,
seeing the
okay.
slides of
Okay,
Dr.
okay,
Mihir
okay,
Sarkar.
okay.
We just go on telling the next.
Okay. Good evening, everyone. Today I'll be discussing about the dyskalemia, the disorders of the potassium metabolism. Just before coming to that, I'm just discussing very briefly 2 cases. Please move the slide. Yeah, just a 2-year-old girl admitted with ARDS, ventilated, and she was on IV fluids, DNS with KCL, and suddenly in the ECG it was showing this tall peak T waves, and at that time the resident doctor, he told to do an ABG, and at that time potassium was 6.5 and the lab value was 7. Next slide. Another child, basically this occurred when I was doing my duty. 4 years old child, actually after about 10 days of intubation, he was extubated on high flow, and just on the next day of his extubation, he started having few episodes of tachycardia, just very brief episode of tachycardia, and then bradycardia started. His heart rate was around 40 and it was going down further. He was gasping. Immediately CPR was started and he was reintubated and put on mechanical ventilation. ABG was done at that time. We showed pH was normal, 7.3, PCO2 was 51, sodium was 137, potassium was very low, it was 1.5, and calcium was 1.2. And there was a background like the child was on Lasix infusion. Okay, so I will again discuss it later. Now, coming to the metabolism. Next slide. We all know that potassium is the second most abundant cation. Majority of body potassium is intracellular. It is 98% and it's mostly in the skeletal muscle. And we know that the intracellular concentration is 140 to 150 milliequivalent per liter. And 2% is extracellular. Concentration is 3.5 to 4.5 milliequivalent per liter. So there's a huge difference between the intracellular concentration and the extracellular concentration. And this gradient basically is being maintained by the sodium potassium ATPase pump. But this gradient is very important because it produces the resting membrane potential, which is important for nerve conduction, skeletal and cardiac muscle contractility. There are certain factors which affect this pump like insulin, glucagon, catecholamine, aldosterone, and acid-base status of our body. As we can see in this picture, that is the intercellular potassium is 150 and the extracellular is 4.5, and it's being maintained by the sodium potassium ATPase pump. Basically, 2 potassium is going in and it is 3 sodium is going out. So this maintains the electrochemical gradient and sets the resting membrane potential. Our daily recommendation is around 1 to 2 milliequivalent per kg intake, and it gets absorbed in the small intestine. Excretion is in kidneys. It's freely filtered at glomerulus, but 90% is reabsorbed, and potassium 10% is basically secreted. Tubular secretion basically regulates the amount of potassium in urine. As plasma concentration increases, the tubular secretion also increases. So just facts connected with this, like during osmotic diuresis, kidneys absorb less potassium. So hyperkalemia occurs in decay. And also we should keep in mind that in chronic potassium depletion, potassium shifts out of cells. So there is alteration in the electrical conductance minimized. Whatever we see the signs and symptoms, and this actually occur due to the acute changes. So these acute changes must be treated immediately. So coming to the hyperkalemia, what is hyperkalemia? When the serum potassium concentration is more than 5.5 milliequivalent per liter. It is moderate when it is 6 to 7 milliequivalent per liter, and is severe when it is more than 7 milliequivalent per liter. Next slide. And what are the causes of hyperkalemia? First of all, is the spurious causes, that is due to hemolysis, due to tissue ischemia, thrombocytosis, or leukocytosis. Whenever we put a very tight tourniquet and then the blood reports come, potassium comes to be very high. These are all the spurious causes. It can be due to increased intake. Suppose if you are giving any oral potassium supplementation, or you are giving potassium in IV fluids, due to blood transfusion. Transcellular shifts, this is very important. Acidosis, insulin deficiency, these are all causes hyperkalemia. And other the syndrome that are associated, like tumor lysis syndrome, when there is a high cell breakdown, basically at that time hyperkalemia occurs. If there is any hemolysis or rhabdomyolysis, like in snake bite, hyperkalemia can occur, and it's also associated with malignant hyperthermia. Other causes, due to decreased excretion, like if there is any primary adrenal disease, 21 hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency, CAH, adrenoleukodystrophy, renal failure, kidney transplant, pseudo hyperaldosteronism 1 and 2, and Bartter syndrome. And all the medications like ARB, ACE inhibitors, potassium sparing diuretics, NSAIDs, or calcineurin inhibitor. So coming to the clinical manifestations, we all know that potassium is very important in the membrane polarization. This I have discussed earlier. So hyperkalemia basically causes weakness, confusion, muscular or respiratory paralysis, ventricular arrhythmia, and asystole. So there are certain ECG changes, basically that varies with the serum potassium concentration. When it's between 5.5 to 6.5, there is a tall peak tented T waves with PR interval shortening. If it is between 6.5 to 7.5, this is a widening of the QRS complex with increased PR interval. If it is between 7 to 8, is broad amplitude, low amplitude P waves, QT prolongation. There can be ST elevation or depression. And more than 8, that is P waves disappear. There is marked widening of QRS complex, sine wave pattern, and this is a very high risk for ventricular fibrillation or asystole. As we can see from the ECG, initial when it's a mild, there is peak T waves with prolonged PR segment. In case of the moderate hyperkalemia, we can see the loss of P wave and the QRS complex is getting prolonged. And if it's severe, it's just a sine wave pattern. So this is very dangerous. So diagnosis, first of all, we have to rule out whether it's a spurious cause of hyperkalemia, because whenever these lab reports come, what happens, we again try to repeat it. We tell now you repeat the sample, and then we have to see whether any medication the child is receiving or not, if there is any increased WBC count, if there is any renal insufficiency, whether how is the pH, whether it is metabolic acidosis or not, or the child is having any tumor lysis syndrome and is getting any chemotherapy drugs or not. And coming to the lab, then after that, basically we check the serum levels of creatinine, renin, aldosterone, urinary potassium excretion, and transtubular potassium gradient. This transtubular potassium gradient, basically it has a formula. If you can know the serum and the urine potassium and the serum and urine osmolarity, we can calculate that. This basically helps to differentiate that whether there is aldosterone deficiency or not. Generally, if it is more than 7, due to increased secretion of potassium in the collecting duct under the influence of aldosterone. If it is less than 5, then there is inappropriate aldosterone effect. And also whether it is due to the aldosterone deficiency or due to resistance, that also we can check. If by giving fludrocortisone, if the level increases more than 7, then it is a deficiency. But if it doesn't increase, then it is resistance. So coming to the management. So what will be my goals? My goals is we should correct it when ECG changes are present, irrespective of the serum level, or when the level is more than 6.5. So what we have to do, we have to stabilize the heart first, remove potassium from the body, monitor levels, and treat the underlying cause. So stabilizing cardiac membrane is very important. We can do it by calcium chloride or calcium gluconate. Generally, we do it by calcium gluconate. And we prevent this intracellular shift of potassium, that is a transcellular shift, which I have discussed earlier. So this can be given with insulin glucose, salbutamol nebulization, or sodium bicarbonate. And restricting potassium intake, that is, we have to decrease the body potassium. We have to remove all potassium containing fluids or medications. We can, if we need an acute reduction of potassium, we can go for the RRT, renal replacement therapy, and potassium binding resins. So just I've told that calcium increases basically the cellular threshold potential, restoring the normal difference between the RMP and firing threshold. Generally, we give calcium gluconate 0.5 to 1 ml per kg over 10 to 15 minutes under cardiac monitoring. 1:1 ratio for peripheral use, and NEAT we can use for central. And insulin glucose also we can use, that is 0.5 gram per kg with 0.1 unit per kg of insulin over 30 minutes. We can give salbutamol nebulization, that is if it is less than 25 kg is 2.5 mg, more than 25 kg is 5 mg, and more than 15 kg is 10 mg. Sodium bicarbonate basically is alkaline pH, it shifts the potassium intracellular, and sodium also increases the distal tubular potassium excretion. It is very much effective in acidotic patient. We can use, that is sodium bicarbonate 1 to 2 milliequivalent per kg per dose. And if kidneys are working, we can use diuretics. And if you need an acute reduction, we can use this RRT. If the child is hemodynamically stable, then hemodialysis, and if it's unstable, then CVVH, and resins we can use 1 gram per kg 8 hourly. It has been seen that this insulin glucose and salbutamol nebulization, if we give combined, this much better than doing it alone. And if the child is having acidosis, we should give sodium bicarbonate. And regarding salbutamol, there is no such difference in efficacy between intravenous salbutamol or nebulization. Next. Okay, so the monitoring, we have to prevent the recurrence, restriction of potassium intake, and we have to check again serum potassium level within 1 to 2 hours. So coming to hypokalemia. Hypokalemia, when serum potassium is less than 3.5 milliequivalent per liter, is life-threatening when it is less than 2.5. So what are the causes of hypokalemia? The spurious causes: high total leukocyte count, transcellular shifts like alkalosis, insulin beta agonist, or high refeeding syndrome. There are certain drugs like alpha adrenergic agonist or theophylline. Due to decreased intake also, there are some extrarenal and renal causes. Extrarenal like diarrhea or laxatives, and renal causes, if it is associated with metabolic acidosis, it can be due to the renal tubular acidosis or DKA. With metabolic alkalosis, it can be cystic fibrosis if the urine chloride is low, and if the urine chloride is high. If the BP is normal, then the renal tubular defects, and if the BP is high, is hypertension, hyperaldosteronism, or Cushing syndrome. Hypomagnesemia, Bartter syndrome, Gitelman syndrome, any renin secreting tumor, or 17 beta hydroxylase deficiency and 11 beta hydroxylase deficiency. So clinical manifestations, basically it causes membrane hyperpolarization and impairs the muscle contraction. Mild hypokalemia may not cause any symptoms, but moderate hypokalemia causes muscular weakness, myalgia, muscle cramps, and ileus. And severe hypokalemia, facet paralysis, and bradyarrhythmia. As we can see, the ECG changes. This is a normal one, and the lower one is the hypokalemia. We can see the slightly prolonged PR interval. This can be a shallow T wave or a prominent U wave. Generally, in the ECG leads in our PSU, we see this prominent U wave, and then we order for an ABG and lab values. So this prominent U wave is very specific of hypokalemia. So diagnosis. So diagnosis, we have to again check the pH, that is good. We have to do a blood gas. We have to check the blood pressure. We have to send the electrolytes, urea, creatinine, urine potassium and chloride, urine potassium creatinine ratio, and fractional excretion of potassium. Okay, so there is a very big algorithm like how we can diagnose whether it is renal causes or external causes. I'm just going through this. If the urine potassium is less than 20, if the fractional excretion of potassium is less than 6, or potassium creatinine ratio, is less than 13, then external losses like diarrhea or transcellular shifts. And if the urine potassium is more than 20, fractional restriction of potassium is more than 6, then renal losses. And in the renal losses, if the blood pressure is normal, then we can see if there is metabolic acidosis, then is RT or DKA, is alkalosis, is Bartter or Gitelman. Next slide. Okay, now if the blood pressure is high, that I have discussed earlier, if the blood pressure is high, we should check the plasma renin and aldosterone. And if both is high, then we should suspect renin secreting tumor. If both are low, then Cushing syndrome or exogenous steroids or CAH. And if renin is low and aldosterone is high, then we should suspect adrenal hyperplasia. Okay, now treatment, potassium chloride is generally preferred. Children who having hypophosphatemia, like in Fanconi syndrome, we can give potassium phosphate. Correction is basically 0.25 to 0.5 millimole per kg, and it's 0.5 millimole per kg per hour via a central line. Maximum is 20 to 40 millimole per hour, and if it is to the peripheral line, 0.2 millimole per kg per hour. Maximum is 20 millimole per hour. And in the peripheral line, we can give 60 milliequivalent per liter. That is generally when we prescribe the fluids like DNS is to KCl 100:3. And if it is central line, up to 80 milliequivalent per liter we can give. Sometimes also give oral maintenance doses like 1 to 4 milliequivalent per kg per day. And potassium chloride basically is used in alkalosis and citrate in RTA. Sometimes if we use Lasix infusion, basically we also add spironolactone, but we have to keep in mind that this suddenly can cause hyperkalemia. So we have to check the potassium regularly, and we should always rule out also hypomagnesemia, because this magnesium actually causes increased potassium losses through urine. So if we don't correct hypomagnesemia, we can't treat the hypokalemia. Hypokalemia becomes refractory to treatment. So this is very important. So next slide. So things to remember, we have to always rule out the spurious causes, rule out hypomagnesemia, and whenever we are getting a potassium value, we should again send to the lab. Lab value denotes the serum value. Ongoing losses we should take into consideration during replacement, and we should keep in mind whether the child is receiving any drugs like diuretics. They can cause hypokalemia, and there is also a mimicker, that is hypophosphatemia. Suppose a child can have a flaccid paralysis, and if you're just thinking, no, the child is having hypokalemia, if you see, suppose the potassium is normal, the phosphate is low. So this is a mimicker we should keep in mind. Acidosis causes hyperkalemia, hypokalemia, and alkalosis occurs in RTA, decay, or carbonic anhydrase inhibitor intake. Thank you.
Thank you, Dr. Dasgupta, for finishing much earlier in time. But there are a lot of questions in the chat box. If you like to answer the questions. So, Dr. Mihir, can you just read out the questions?
Yes, thank you, Sohaili. This is a very lucid presentation. Now I'm going to the questions. Okay. Okay, oral potassium citrate is used for renal stone. Can it cause hyperkalemia? After how many days of AC inhibitor should we check for potassium? Check creatinine, actually, is written. First question is, oral potassium citrate is used for renal stones. Can it cause hyperkalemia?
I really don't know. The second one, basically when you use AC inhibitors, we generally check creatinine after 1 to 2 days, and potassium we generally check every day. In PISO, basically we check every day, at least 48 hours.
Can you comment on that? Any oral potassium citrate used for
Usually
renal
for
stone?
pediatric renal stone, it's a usually dictum to give the potassium citrate whenever the etiology is not proper. And in real case scenario, actually hyperkalemia doesn't happen much. Though we don't monitor it also in a regular fashion, we do it at least every 2 monthly. The reason maybe the dose for this one is not much. Second one, if your kidney is okay, the potassium handling by the kidney is fairly well. And third one, that might be this amount of potassium already the child who is having hypercalciuria or something, the tubules are already in the same disease. Suppose maybe the case of RTA along with hypercalciuria, and that's why we are given this one. So these have been balanced. So that's why in practical scenario, that doesn't happen. Theoretically, that sounds maybe possible, but in practical, that doesn't happen. And the second one, for AC inhibitors, it is ideally noted that usually the initial GFR will be dropping. We are accepting it, and later on, around day 5 or day 6, the creatinine comes to normal again. due to the transient physiology. So if you are checking for potassium part, better to check with 48 hours. If you're checking for a creatinine part, if not any other hypovolemia associated, better to check at day 6 or day 7. And also Dr. Bagar cautioned on day 1 that if your child is admitted with fever or diarrhea, don't start enum at that AC inhibitors at that time. Or if you are giving already AC inhibitors, at least hold that for 5 to 6 days. So otherwise, in a normal child, if you are giving it for hypertension or something else, check your potassium after 48 hours. Your creatinine may be after 5 or 6 days, because on day 2, your creatinine is bound to increase a little bit. Okay. Next question. Can we?
Thank you. There's the one other question is what is the mechanism of hyperkalemia in acidosis? Request from Dr. Urpita Khemka.
Basically, it is causing the transcellular shift. That is the main mechanism. Is that happens also in decay also, that the potassium is basically it's moving out. So that is the main mechanism, transcellular shift in acidosis.
CKD stage 5 can yes, Sumantra, do you want to comment?
What that Soili wants to say, most likely this in case of acidosis, huge amount of H plus within the blood compartment. So that has to be diffused back to the cell. And if it goes in the cell to maintain the electric neutrality, the most amount of cation is potassium within the cell. So that potassium, suppose 10 H plus goes in, 10 potassium just come out during acidosis, and the vice versa in case of alkalosis. Most of the time, though there are exceptions of acidosis with hypokalemia, RT and diarrhea, but this is the most common time. This is the scenario. H plus goes in, equal amount of K plus goes out.
Thank you, Sumantra, for clearing. So in CKD stage 5, can furosemide be helpful?
I don't think so. I think Dr. Shumanta sir will.
This question probably is not related to hypokalemia also, but as a note, but usually in case of CKD, whoever is anuric for a quite long time or maybe oliguric, usually Lasix doesn't help much. But still, we can try at least once. There is no point of trying repeatedly Lasix whenever the urine output is not increased on day on first dose itself, because it will only cause ototoxicity and the child will become deaf. No other advantage on that one. It mostly happens when a CKD child not on dialysis come to us with a low hemoglobin. We want to transfuse this blood, and also at the end of blood transfusion, we want to give some Lasix, which you usually do in our real practice. So at least try once if you need, but if you fail, don't try it repeatedly.
Because in a child who is coming to us with CKD stage 5 has already started having hyperkalemia, I mean, in any case, we will have to move the child to dialysis. So there's no point like trying with furosemide. Maybe if like for the time being, if you want to buy time till you start dialysis, you can try a furosemide. May work, may not work. Best is to start dialysis.
Thank you, Deblina, for your comment. And next is what are the potassium binding resin available?
Resins available, basically we have not given in our PSU. But the dosage is 1 gram per kg, 8 hour TB.
In India, if you are talking about India only, the only regime is what we call that K-bind, that is the calcium polystyrene based regime. Initially, maybe decade previous or in the outside world, the SRS, the sodium polystyrene regimen, is also available. But this sodium polystyrene regimen is already having a huge amount of constipation leading to bowel rupture. And even if with K-bind also, remember, we usually give it with lactulose, with Dufalac, and the dose as Dr. Soili is told. So the only available in India currently is K-bind sachet, and other the Patrinomar, or if you are asking about that one, these Patrinomar are available not in India but outside, and they are also in case of background of CKD and not in acute cases. The other binders.
We'll take 2 more questions, then we'll move to the next session. The next question is, will excessive nebulization with salbutamol can cause hypokalemia in a eukalemic child?
Yes, these things actually had happened in our PSU before. Like if you're giving salbutamol inhalation, I think it's better to check the potassium level, because that case which I discussed, basically the child was having bradycardia and needed CPR. His potassium was so low. Basically, he was we were giving salbutamol nebulizations and we have not checked potassium after like 2 to 3 days, and also he was receiving Lasix infusion. So he was getting Lasix infusion and salbutamol infusion has given. So hypokalemia occurred. So I think it's better if you're giving salbutamol nebulization, we should check potassium.
So next is one the participant asked about the details about the potassium binding resins, the mode, K-axylate resins, and how to give. I think Sumantra has already explained. So I don't think and you can write in the chat box, Sumantro, later
We'll
on.
we'll write.
So I think it is 7 already. Can we move to the next session, and the next other questions can be answered in the chat box?
Okay, fine. Swapn sir, are you taking charge?
Yes, yes.
Okay.
Our next speaker is Dr. Debolina Dasgupta, and she will speak on these hypocalcemia, hypercalcemia, and hypomagnesemia in children. So I'll request Dr. Sumanto to introduce her.
Just a minute, sir. Debolina, are you sharing your screen?
Yes, Dada, I'm sharing it. If I face any issue, then I'll let you know.
You please introduce Debolina.
Okay, fine. Dr. Debolina is one of the brilliant pediatric nephrologists in Kolkata. She has done his fellowship in pediatric nephrology from Sir Gangaram Hospital, New Delhi, and currently she is the faculty in Institute of Child Health, Kolkata, as a pediatric nephrology. And over to you, Dr. Debolina. We are hoping a nice session here.
Thank you, Dada, for the kind introduction, and I thank the organizers for organizing this excellent academic session. So the topic that was given to me was dyscalcemia and hypomagnesemia, which is a very important problem we face, especially when we are practicing in the intensive care units. So before we talk about the various dyscalcemias, we should know a little bit about how the homeostasis is maintained. So I'll talk a bit about that. So basically 20 to 40% of the dietary calcium gets absorbed, and majority of it gets stored in the bones, and only 1% of it is available in the extracellular fluid, out of which 48% remains in the ionized form, which is the active form, and is responsible for carrying out the various extracellular functions. 40% remains bound to proteins like albumin and globulin, and only 12% remains in the complex form. So it is the bones, the intestine, and the kidneys which are responsible for maintaining the calcium pool. And whatever calcium gets filtered in the kidneys, 99% of it gets reabsorbed. So although this is a bit busy slide, but I will make it easy. So majority of the calcium reabsorption occurs in the proximal tubule, and it occurs in a paracellular pathway. And it is mainly a passive process that is driven by the electrochemical gradient that is generated due to the movement of ions like sodium, hydrogen ion, calcium across the luminal membrane. Only 15 to 20% gets reabsorbed in the thick ascending limb of loop of Henle, and here also it gets reabsorbed through the paracellular pathway with the help of claudin 16. And here again, it is driven by the electrochemical gradient created due to movement of ions through the NKCC2 and the ROMK channels. In the DCT, it is reabsorbed through the vanilloid receptors known as TRPV5 and V6. And none of it is reabsorbed in the collecting tubules, but calcium plays a very important role here. Here it tends to regulate the expression of aquaporin, which are responsible for water reabsorption from the tubules. So the normal serum calcium level gets maintained between 8.5 to 10.5 mg per dl or 2.2 to 2.6 millimoles per liter. And the ionized fraction lies between 1.1 to 1.3 millimoles per liter or 4.5 to 5.5 mg per dl. And the main regulators of this calcium level are vitamin D, PTH, calcium sensing receptor, and calcitonin. So here I will try to discuss how the regulation occurs. So suppose there is hypocalcemia. Immediately the calcium sensing receptor senses the hypocalcemia, and it causes release of parathyroid hormone. So the parathyroid hormone then goes and acts on the bones, where it increases osteoclastic activity and bone resorption, so that calcium can pour out from the bones into the extracellular fluid. It also acts on the kidneys, where it increases calcium reabsorption through the DCT, also increases conversion of 25-hydroxyvitamin D to 125-hydroxyvitamin D, which in turn increases the calcium and phosphorus absorption from the intestine, and it also tends to cause bone resorption by increasing the osteoclastic activity. So this is how, even if the calcium level decreases, the calcium level gets restored in the blood thanks to these hormones. Now, what happens when there is hypercalcemia? Hypercalcemia acts on the thyroid gland, from where the calcitonin gets released. Calcitonin inhibits osteoclastic activity and promotes osteoclastic activity, thereby causing the excess calcium in the blood to be absorbed into the bones. On the other hand, the calcium also gets sensed by the calcium sensing receptor on the parathyroid gland, which in turn helps to suppress the PTH secretion and also increases calcium excretion through the urine by decreasing calcium reabsorption from the thick ascending limb of loop of Henle. So this is how grossly the calcium regulation occurs. So we call it hypocalcemia when the serum calcium is less than 8.8. In some books, it is written as 8.5. The cutoff is even lower in case of infants. It's less than 8. And in case of premature infants, it is said to be less than 7.5. And the ionized calcium has to be less than 1.1 millimoles per liter for us to call it hypocalcemia. Remember, suppose you get a child who comes to your hospital, gets admitted, you get a total serum calcium done, and you see that it is low. So it is always very important that you rule out pseudo-hypocalcemia. Hypoalbuminemia can cause pseudo-hypocalcemia. How? Because the albumin-bound fraction decreases. That causes the total serum calcium level to decrease, but the ionized fraction remains normal. So that does not affect the extracellular functions carried out by the calcium. So how do we, there's a method to correct that. So how do we do that? Remember, for every 1 gram per dl decrease in serum albumin below the 4 gram per dl mark, serum calcium decreases by 0.8. So the corrected serum calcium in mg per dl is given as measured serum calcium that is reported by the lab plus 0.8 into 4 minus serum albumin. So suppose you get a child who has a serum albumin of 3 gram per dl and the lab tells you that the total serum calcium is 6.7, then the corrected serum calcium will be 6.7 plus 0.8 into 4 minus 3, which is equal to 7.5. So 7.5 will be the corrected serum calcium in this child. And always, always, always check the ionized calcium before you jump into the conclusion that, okay, this child has hypocalcemia. So now if a child comes to you with hypocalcemia, what are the manifestations that can occur? So if the fall in serum calcium level has been acute, then we know that it can result in increased neuronal excitability. Always keep in mind, hypocalcemia causes increased neuronal excitability, but decreases muscular transmission. So there will be hypotonia, but there will be tetany. So what exactly is tetany? It occurs due to increased neuronal excitability, especially occurs when the ionized calcium is less than 1.1 millimoles per liter, or the total serum calcium is less than 7 to 7.5, can even occur at higher levels of these two, especially if there is a concomitant metabolic alkalosis present. So it usually entails sensory symptoms to start with, which can be like acral and perioral paresthesias, motor manifestations in the form of myalgia, muscle cramps, carpopedal spasm, laryngeal stridor, and rarely autonomic manifestations like diaphoresis and bronchospasm. If the level falls even further, then it can result in seizures, which can range from generalized tonic seizure, even focal seizures also rarely, can cause apnea in neonates. And it will cause depressed myocardial contractility, hypotension, can even precipitate congestive cardiac failure. It can cause prolonged QTC interval, which can give rise to dysrhythmias and heart block rarely. Now, sometimes what happens, the child may not have overt manifestation of hypocalcemia, but the child may have some latent signs which we can unmask. So these are Trujo sign and Voschtek sign. I think everybody will be knowing about the signs, but let us still go through it once. So Trujo sign is something which is unmasked if we inflate a BP cuff above the systolic blood pressure for 3 minutes. So that actually causes ischemia that precipitates tetany if there is a concomitant hypocalcemia present. So that is typically characterized by flexion of the wrist, flexion of the metacarpophalangeal joint, extension of the interphalangeal joint, and forced reduction of the thumb. Another sign is the Voschtek sign, which happens when we tap the facial nerve in front of the tragus, and that will cause twitching of the ipsilateral facial muscles. Now, if the hypocalcemia is chronic, it can result in papilledema. Very often the manifestations depend upon the underlying cause. For example, subcapsular cataract, basal ganglia calcification can occur if there is hypoparathyroidism. Ectodermal and dental defects and other features of rickets can occur if there is a calcipenic ricket present. So what are the various conditions that can give rise to hypocalcemia? So broadly keep in mind, hypocalcemia can occur due to suppressed PTH. Hypocalcemia can occur even when the PTH is elevated, and miscellaneous conditions that do not affect the PTH level. So there is hypocalcemia, there is suppression of PTH, means that probably there is something problematic with the parathyroid gland. Either it was not developed properly, or there is a parathormone hormone synthesis defect that can occur in a whole lot of syndromes, which I'm not going through here due to lack of time. Again, as I told earlier, calcium sensing receptor activating mutations can also suppress PTH secretion. and that can also give rise to hypocalcemia. Autoimmune destruction of the parathyroid gland, certain injuries to the parathyroid gland can cause hypocalcemia. Hypomagnesemia, as Dr. Shoheli explained previously, can also, she explained about hypokalemia, but hypomagnesemias can also cause hypocalcemias by suppressing PTH secretion. Again, hungry bone syndrome, sepsis, HIV infection, these can also suppress PTH. So if the PTH is elevated in the face of hypocalcemia, then probably we should look at the vitamin D axis, which may be defective. For example, there may be a deficiency of vitamin D. There may be decreased conversion, decreased 25-hydroxylation of vitamin D, as can occur if there is hepatic dysfunction or some genetic defect. There may be decreased conversion into active vitamin D that can occur in renal dysfunctions and other genetic defects concerning the enzymes. Or there can be end organ refractoriness to activated vitamin D that can happen in vitamin D dependent ricket type 2. Sometimes they can be completely vitamin D independent also. For example, if calcium itself is deficient in diet, or if there is malabsorption, if there is pseudo hypoparathyroidism where parathyroid is elevated but not able to act on the receptors, again in conditions like acute pancreatitis where the calcium is getting removed from the circulation. And other conditions like chelation, as in massive blood transfusion, hyperphosphatemia, as in tumor lysis syndrome, can cause calcium levels to fall rapidly without affecting the PTH levels. Alkalosis can decrease ionized calcium fraction. Osteopetrosis, osteoblastic bone mets can cause increased calcium reabsorption into the bones, thereby decreasing hypocalcemia. Various drugs and poisons can also cause hypocalcemia. So if you have a child who presents to you with hypocalcemia, first you confirm that it is true hypocalcemia. So you check the serum albumin, check the ionized calcium. Once you have confirmed it, then you should look at the serum phosphorus levels and the PTH levels. So if there is hypocalcemia, along with that, you find that the PTH is low or normal and the phosphorus is high, that means there is something wrong with the PTH gland, because under conditions, normal conditions, the PTH should have been elevated, but it is not elevated. So then you should first and foremost look at the serum magnesium. Low serum magnesium can cause suppression of PTH. So hypomagnesemia will be the reason. If you see the serum magnesium is normal, then you check whether the child is having hypercalciuria. So hypercalciuria in the face of hypocalcemia can happen if there is activating mutation of calcium sensing receptors, but in all other conditions, you expect the urine calcium creatinine ratio to be low. So if it is low, then it is probably primary hypoparathyroidism we are dealing with. Now, suppose you see that the child has low phosphorus and high PTH. That means PTH is not the reason why the calcium is depressed. Then you should look at the vitamin D axis. 25-hydroxy vitamin D you get done. If it is low, then vitamin D deficiency. If it is normal, you get the activated vitamin D level done. If it is low, then it is due to decreased conversion into activated vitamin D, so viridia type 1. If it is high, that means there is end organ refractoriness to activated vitamin D, so viridia type 2. Normal can be there in all cases where there is, where there is removal from the circulation, as in case of acute pancreatitis. So how do we manage? If the child is symptomatic, we have to give a IV calcium correction. It always has to be with calcium gluconate in children. Avoid calcium chloride, which can cause tissue necrosis due to extravasation. Even when you're giving calcium gluconate, be very careful. It should not extravasate. Otherwise, it can give rise to very bad tissue necrosis. So if you give IV correction, you should give it 10% calcium gluconate at the dose of 1 to 2 ml per kg, double diluted in 5% dextrose over 10 to 15 minutes under cardiac monitoring, because it can cause bradycardia. Until your symptoms resolve, you have to continue that at 6 to 8 hour interval. And after that, you have to put the child on oral calcium supplementation. Always keep in mind, if there is a concomitant metabolic acidosis present together with hypocalcemia, as seen in many children with CKD, do not correct the metabolic acidosis first, whatever be the serum bicarb level, because that can precipitate tetany. So always correct calcium and then you correct the metabolic acidosis. When you do oral calcium supplementation, there are a number of salts available like calcium carbonate acetate. You can give at 50 to 75 mg per kg per day in divided doses. Always avoid giving any antacid with carbonate because the bioavailability will decrease. And obviously the underlying etiology will have to be treated. For example, if there is hypomagnesemia, treat with magnesium. If you have hypovitaminosis D, then it has to be corrected with vitamin D. So now moving on to hypercalcemia. I'm sorry, I'm moving very fast because there's not much time and the complex is a bit, the topic is a bit complex. So we call it hypercalcemia if the serum calcium is more than 10.5 mg per dl. Now, what can be the manifestations of hypercalcemia? When do you suspect? keep in mind, it depends on the level of the serum calcium and also with the rapidity with which the hypercalcemia developed. So if it is less than 12, then it
Tina,
is
you have 15 minutes, so you can go, I think, in a slow in that manner. So you have 15 minutes now.
right, sir. Okay, sir. So if it's less than 12, then it is mild. And usually in that case, it does not cause any symptoms. Okay. If it is moderate, like 12 to 14, it will cause some symptoms. Why these symptoms happen, I will explain later. But it can cause polyuria, polydipsia, dehydration, anorexia, nausea. And if it is severe, that is, if the level is more than 14 mg per dl, then it can give rise to a whole lot of overt CNS symptoms, gastrointestinal symptoms, and renal dysfunction. So what are the neurological symptoms that we can see? As I told earlier, if you remember, hypocalcemia causes increased neuronal excitability. So hypercalcemia will decrease neuronal excitability. So severe hypercalcemia will tend to cause lethargy, drowsiness, irritability, coma. But this is when the hypercalcemia is severe. In mild to moderate cases, it can cause subtle neuropsychiatric manifestations also, like cognitive dysfunction, anxiety, depression, which may not be always possible to notice. On the cardiovascular system, it can shorten the QT interval, but rarely it causes arrhythmias. Sometimes it can cause ST segment elevation also. Gastrointestinal symptoms are very non-specific to begin with, like anorexia, nausea, and constipation. But when the serum calcium level exceeds 14 mg per dl, it can give rise to peptic ulcer and pancreatitis, because calcium, we know, helps in activation of gastrin and a whole lot of pancreatic enzymes, which will get activated and can result in peptic ulcer and pancreatitis. And musculoskeletal, it will cause hypotonia. Renal manifestations, it's very important to understand why these renal manifestations happen when there is hypercalcemia. So whenever there is hypercalcemia, there will be both free water as well as solute diuresis. So if I go back to that homeostasis picture, yeah. So if this picture is visible, you can see that in the thick ascending limb of loop of Henle, there is a calcium sensing receptor that is present in the basolateral membrane. So whenever there is hypercalcemia, calcium binds with the calcium sensing receptor and it inhibits the NKCC2 and the ROMK channel, as a result of which sodium, potassium chloride doesn't get reabsorbed. So there is a whole lot of solute diuresis. Along with that, the hypercalcemia also acts on the calcium sensing receptor that is present on the luminal membrane of the collecting tubule. The calcium sensing receptor actually is responsible for inhibiting the expression of aquaporin. So as a result of that, ADH cannot act, and as a result of that, water reabsorption cannot occur. So hypercalcemia acting through calcium sensing receptors mostly will result in both free water and solute diuresis, and as a result of that, there will be a lot of polyuria. And often these children have anorexia, and that's why they end up getting severely dehydrated. It can also cause distal renal tubular acidosis. It also causes decreased GFR. Why? Because hypercalcemia causes renal vasoconstriction, plus already the child is dehydrated to begin with, so it will result in decrease in GFR. Again, hypercalcemia will give rise to hypercalciuria and nephrolithiasis. Nephrolithiasis is also partly because of decreased citrate excretion in the urine. So these are the acute manifestations that can happen. Chronically, if a child is hypercalcemic, it will lead to calcium deposition in various tissues. So it will result in nephrocalcinosis, it will result in band keratopathy, it can result in metastatic calcifications elsewhere. So what are the various conditions that can give rise to hypercalcemia? One is due to increased PTH. PTH increases calcium secretion. So if PTH is increased, there will be increased amount of calcium in the serum. So that can happen if there is a parathyroid adenoma. Remember, we told you that calcium sensing receptor suppresses PTH. So if there is an inactivating mutation of calcium sensing receptor, it can increase your PTH levels and thereby cause hypercalcemia. Also in CKD, not in all CKD, CKDs usually have hypocalcemia, but if a child is having tertiary hyperparathyroidism, adynamic bone disease, sometimes after renal transplant, they can have hypercalcemia as well. Another culprit that can be responsible for giving rise to hypercalcemia is vitamin D excess. That can be due to excessive administration of vitamin D. That can be due to increased conversion of 25-hydroxyvitamin D to 125-hydroxyvitamin D. That actually happens in various granulomatous diseases like tuberculosis, sarcoidosis. So this is why hypercalcemia occurs in sarcoidosis. Again, if the activated vitamin D is not broken down, the enzyme responsible is 24 alpha hydroxylase. If that activity is decreased, then there will be increased action of activated vitamin D, resulting in hypercalcemia as seen in infantile hypercalcemia cases. Williams syndrome, we all know hypercalcemia is a part and parcel of Williams syndrome, and that happens because of augmented vitamin D receptor. Hypophosphatasia can also cause hypercalcemia by increasing calcitriol formation. There are certain other conditions where the bone resorption may be increased independent of PTH or vitamin D. So what are these conditions? Humoral hypercalcemia of malignancy, which occurs due to increase in PTH-related peptide, which is not the same as PTH. Or if there is increased activation of PTH-related peptide receptor, as in case of Jansen's metaphyseal dysplasia, we can have hypercalcemia. If there is prolonged immobilization, many a times we see that CP children may be having hypercalcemia, that is because of immobilization. If there are osteolytic secondaries, if there is vitamin A overdose, and certain drugs like thiazide diuretics, they can cause hypercalcemia. So if a child comes to us with hypercalcemia, we should again check the serum albumin level, because if the albumin levels are high, that can cause a false hypercalcemia. We should also look at the ionized calcium level. And once we have confirmed that, okay, it is true hypercalcemia to start with, we should check the serum phosphate. So if the serum phosphate is low, that means what? There is increased calcium and there is low phosphate. Keep in mind, PTH is responsible for increasing serum calcium levels and decreasing phosphate levels. So it indirectly points towards probably your PTH is going to be high. So you do a PTH, you find that it's high, you again check whether there is hypercalciuria. So under normal conditions, if a child is having hypercalcemia, the kidney should try to compensate and cause hypercalciuria. So if there is hypercalciuria, then probably it is primary hyperparathyroidism to begin with. However, if it is low, I'm sorry, I can't show you here, this is not going. If it is low, so a child is having hypercalcemia without hypercalciuria, rather there is hypocalciuria. So that happens when your CASR receptors get inactivated, because normally they are responsible for suppressing PTH action, thereby causing hypocalcemia, and they are responsible for increasing calcium excretion. So if they get inactivated, that can result in hypercalcemia and hypocalciuria. Now, suppose you check the serum phosphate, you find that it's high. So now you have a tricky situation. There is both increased serum calcium and there is both increased serum phosphorus. PTH should be low in this case, but it may be high in case of CKD. So you get a PTH done. If it is high, then it is CKD. You can check the serum creatinine in that case. But if the PTH is low, then probably it is pointing towards your vitamin D axis. So if your 25 hydroxy vitamin D levels are high, then probably it is iatrogenic. If the 25 hydroxy vitamin D levels are low, then you check the activated vitamin D. If it is high, then probably there is increased activation as seen in granulomatous diseases. But if it is low or normal, so that means probably there is increased bone resorption that I had pointed out in all these conditions, right? So how do I manage a child with hypercalcemia? So if it's just a mild asymptomatic case, I don't need to create a lot of fuss. I can just stop the whatever calcium and vitamin D supplement the child is getting, ensure that the child is not getting a high calcium diet, and I can treat the underlying condition, and I just have to prevent dehydration, that's it. But if the child is coming to me with moderate elevation like 12 to 14, but the child still has not developed any symptoms, I can just do what I did before. I can stop calcium vitamin D supplements. I can treat the underlying condition. But at the same time, I need to increase the calcium excretion in urine to normalize the serum calcium levels. So how will I do that? If I do IV hydration with isotonic saline, that itself will tend to cause hypercalciuria. Why? Because I am increasing sodium delivery to my kidneys. And if I increase sodium delivery to my kidneys, there will be increased sodium reabsorption, and in turn, there will be increased calcium excretion. So if I just give IV hydration with isotonic saline 1.5 to 2 times normal maintenance, I can achieve hypercalciuria. I may add furosemide to that, 1 mg per kg per dose 6 hourly. But whenever you're adding furosemide, be very careful. You should not cause intravascular volume depletion, because that will again precipitate symptoms of hypercalcemia. And you should also monitor serum potassium magnesium. And this maneuver helps to reduce the serum calcium by 1 to 3 mg per dl. Now, if the child has moderate elevation but is symptomatic, or has severe elevation, that is more than 14 mg per dl, then you do whatever you did earlier. Along with that, you need to ensure that your calcium moves from your serum into the bones. For that, you add on calcitonin. Calcitonin is a fast-acting agent in this case. So you give subcutaneous or intramuscular calcitonin 4 units per kg 12 hourly. If there is no proper response, you can increase it to 8 units per kg 6 hourly, but you give it for a maximum duration of 48 hours because calcitonin tends to develop tachyphylaxis very quickly and the response will blunt out. Another thing that you will start right on day 1 is giving IV bisphosphonates, which increase osteoblastic activity. So you cannot use zoledronate or alendronate in children as far as I know. So we give only IV pamidronate. You give at the dose of 0.5 to 1 mg per kg per dose, properly diluted over 4 hours for 3 consecutive days. Definitely you have to monitor for hypocalcemia, for hypersensitivity reactions. A very important cause of hypercalcemia is often the malignancies, and in those cases, your hypercalcemia may prove to be recurrent or refractory. In that case, you may have to repeat this IV pamidronate every 3 to 4 weeks. And when you do that, there are chances that you may get some adverse events like osteonecrosis of jaw and femur fractures. So you have to watch out for this. IV hydrocortisone can be helpful in a selected number of cases because it basically reduces calcitriol production by mononuclear cells and lymph nodes, and it also decreases intestinal calcium absorption. So it is useful in granulomatous diseases, paraneoplastic syndrome, and vitamin D intoxication, and this will also take some 3 to 5 days time. So both this IV pamidronate and hydrocortisone, they are slow acting agents, but they have to be started on day 1. To tide over the time till their action starts appearing, we have to give calcitonin. And whatever is the underlying condition, we have to treat it. So now moving on to magnesium homeostasis. So again, a little bit about the magnesium homeostasis. Magnesium, similar to calcium, 30 to 40% gets absorbed. But keep in mind that unlike calcium, where the extracellular calcium pool, it equilibrates with the intracellular calcium pool very rapidly. In case of magnesium, although the majority of it is stored in the bones and also sometimes in the muscles and liver, but this intracellular pool is not readily available for exchange with the extracellular pool. So if there is a sudden decrease in serum magnesium level, you do not expect the bones or the skeletal muscles and liver to compensate. Rather, it is the kidneys which will come into play. So your serum magnesium level gets regulated mainly by your intake and absorption, and also by the renal excretion or the renal reabsorption. Okay, so in the kidneys, more or less, there's no need to get scared with this diagram. Just keep in mind the magnesium usually gets reabsorbed along with the calcium. Majority of the reabsorption occurs in the thick ascending limb of loop of Henle in the paracellular pathway, some 15 to 20% in the proximal tubule in the paracellular pathway along with calcium. And in the DCT forms the main site where the regulation will happen, as shown in this picture. Here it gets reabsorbed with the help of certain channels called TRP, MP6, M6 and M7. So the magnesium level gets tightly regulated between 1.7 and 2.2 mg per dl. And as I told earlier, it will depend upon the intestinal absorption and renal excretion. Each will depend upon each other. That is, the more increased absorption occurs, renal excretion will increase. And that again gets regulated by a whole lot of factors like serum magnesium, serum calcium, acid-base status, calcitonin, PTH, etc. So we call it hypomagnesemia when the serum magnesium is less than 1.7 mg per dl. Manifestations are non-specific. In most of the cases, the manifestations are due to the concomitant hypocalcemia and hypokalemia that occurs. Keep in mind, like hypocalcemia, hypomagnesemia also increases neuronal excitability, but it decreases the muscular contractility. So hypomagnesemia will cause tremors, tetany, seizures. It can cause vertigo, altered mental status, ataxia. Chronic hypermagnesemia, since magnesium is an important component of the skeleton, can cause increased fragility of the skeleton, decrease the skeletal growth. And in the ECG, it can give rise to flat T waves, U waves, and prolonged PR or QT interval, often with arrhythmias. So in which conditions will you expect hypomagnesemia to occur? Usually dietary deficiency is not that common. Rather, if our diet contains some binders or something that prevents magnesium absorption, that can result in hypomagnesemia. For example, if you're using antacids like PPIs, again, if a child is on parenteral nutrition where you're not adding magnesium, it can result in severe hypomagnesemia. There can be certain conditions that causes redistribution of the magnesium from the extracellular to the intracellular compartment, as in case of hungry bone syndrome, in case of refeeding syndrome following treatment of DKA. In these conditions, you may find hypomagnesemia. More commonly, hypomagnesemia occurs due to increased losses. The losses can be through the extrarenal route or through the renal route. So extrarenal route, how will you understand? The fractional excretion of magnesium in urine will be usually low, less than 2%, which means that the kidneys are trying to conserve magnesium. So that will give you a clue that probably the losses are occurring through an extrarenal route. So that can be through the GI tract, like in diarrhea, malabsorption, intestinal fistula, short bowel syndrome, if the child is on prolonged NG suction, or it can be through the skin, as in case of extensive burns and sweating. In renal losses, the fractional excretion of magnesium will be more than 5%. That can happen in case of hypercalcemia. So hypermagnesemia, hypercalcemia can decrease magnesium reabsorption from the kidneys, and that can cause increased magnesium losses in kidney through kidney, and that can result in hypercalcemia. Any condition that causes diuresis, salt diuresis, for example, diuretic phase of acute tubular necrosis, post-obstructive diuresis, prolonged diabetes mellitus can cause hypomagnesemia. Certain drugs interfere with reabsorption of magnesium through the magnesium channels, like your calcineurin inhibitors, amphotericin, loop diuretics, thiazide diuretics. These are very notorious for causing hypomagnesemia. And there is a whole bunch of inherited renal magnesium wasting disorders, which are not going to discuss here. They can also result in hypomagnesemia. So how do you treat hypomagnesemia? If it is asymptomatic, it's better to go for oral supplementation. Why? Because you should avoid IV magnesium sulfate unless symptomatic. Why? Because if there is rapid correction of hypomagnesemia following IV magnesium correction, the kidneys will again tend to excrete a lot of magnesium in urine, and you can end up actually losing 50% of whatever you give IV. Along with that, if you're giving IV magnesium sulfate, the sulfate can sometimes combine with the calcium, and that can precipitate your hypocalcemia and tetany. So that's why unless the child is symptomatic or having severe hypomagnesemia, you try to give oral supplementation. It has to be in a high dose, 100 to 200 mg per kg per dose, 4 to 6 hourly. And once the magnesium gets corrected, you give a maintenance dose at 30 to 60 mg per kg per day. If the child is symptomatic or has severe hypomagnesemia less than 1.25, then you have to give a slow parenteral correction. You can give 50% max self correction at the dose of 25 to 50 mg per kg per dose, or 0.1 ml per kg per dose, maximum 2 gram per dose, diluted in normal saline to achieve a 20% concentration. And that can be given as infusion over 30 minutes at 6-hourly interval for 3 to 4 doses. Whenever you're giving magnesium correction, you have to monitor the serum magnesium levels, ECG, because that can precipitate arrhythmias. It can cause hypotension, it can cause respiratory depression. That's why it's very important that you monitor. And if during giving max self correction, it results in ECG changes, you have to keep IV calcium chloride and calcium gluconate ready as an antidote. And definitely, very often, it will remain associated with hypocalcemia, hypokalemia. So you have to correct the concomitant coexistent electrolyte disturbances, and definitely you have to treat the underlying cause. So these are some of the magnesium preparations. So these are some oral preparations. You can get magnesium chloride, oxide tablets, gluconate, out of which the magnesium oxide contains the maximum amount of magnesium, but again, the bioavailability is less. So more or less all magnesium supplements are similar. And you have parenteral solutions also, magnesium sulfate in 2 different concentrations. We prefer to use the magnesium sulfate 50%. So take home message, before diagnosing hypocalcemia or hypercalcemia, always check the ionized calcium and the serum albumin. Do consider concomitant acid-based disturbances when you get hypocalcemia. If there is a concomitant metabolic acidosis present, always correct hypocalcemia first before correcting metabolic acidosis, even if you're tempted to do so, because that can result in precipitation of tetany. In any child who presents to you with hypocalcemia, especially if refractory, do look for and treat hypomagnesemia, which is very, very important. And in a child who is presenting to you with any calcium disorder, don't just look at the calcium, but do look at the serum phosphorus, PTH, vitamin D levels, which will help us to narrow down on the etiology and help in definitively managing the hypocalcemia or hypercalcemia better. So thank you. I would be happy to take any questions.
Thank you, Dr. Dasgupta, for a wide coverage of this hypocalcemia, hypercalcemia, hypomagnesemia, hypermagnesemia. So actually, there are a lot of questions, but we are running late of time. I would request you to answer all the question in the chat box.
Sure, sir.
Okay.
Sure, sir. I'll do that. Thank you.
We'll move on to our next session. It will be delivered by Dr. Sananda Majumdar, the fluid in congenital heart disease. So over to you, Dr. Shananda. Can you share your slide?
Yes, sir. Yes, sir. I'm sharing.
I'll request Dr. Sumantro to introduce Dr. Mojumdar. Sumantro?
Yes, sir. I'm here. Yeah. So our next talk is on cardiac region of fluid. So how to adjust our fluid in case of cardiac failure.
Oh,
And
with
to present
congenital heart disease.
congenital heart disease.
With
Yeah, right.
congenital heart disease.
Yes, sir. And for this reason, we are having our next speaker. Just a minute.
Hello, sir.
Just a minute, sir. Have you shared your slide? Yeah, thank you.
Yes, sir. I've shared. Is it visible, sir?
Yeah, it's visible.
Yes.
Thank you. So Dr. Sananda is from MMC Mindapur Medical College. She has completed her MD and she is the current speaker on fluid and balance in case of congenital heart disease with congestive cardiac failure. Over to you, Dr. Sananda.
Okay, sir. Good evening to all my respected teachers and all the delegates. Today, my topic is fluid in congenital heart disease with congestive heart failure. So first thing, we are going to study about the basics of CHF a bit. We are going to review it. So what is the definition of CHF? It's a clinical syndrome in which the heart is unable to provide the required output or unable to dispose systemic or pulmonary venous return adequately, or it's a combination, we can tell, of the above two. So coming to the pathophysiology very briefly, we can divide pathophysiology actually systolic or diastolic combined pump failure, and it is caused due to either structural heart disease or it can be due to rhythm disorder or primary myocardial disorder. As our point of focus here is structural heart disease, so basically two things can happen, either a pressure overload or volume overload, and this can lead to the systolic or diastolic or the combined pump failure with an increase in the pulmonary capillary wedge pressure to greater than 18 millimeter of mercury, then we can call it as a heart failure or congestive heart failure. So coming to the compensatory mechanisms which are coming into effect in heart failure, we all know about it. Just a brief recap. That is, the cardiac compensation is increased heart rate, increased contractility. There will be cardiac dilatation and myocardial hypertrophy. Systemic compensation that occurs is increased blood volume, redistribution of the blood flow. There will be increased tissue utilization of oxygen. Now, the neurohormonal, and our main point of interest here, because as we are talking about the fluid balance in congestive heart failure, will be the sympathetic nervous system activation that happens, and main point is the activation of the renin-angiotensin system. What happens is that the circulating blood volume gets decreased, and so the renin gets activated in the kidney, which will in turn activate this RAS system, and this will lead to the increased absorption of water and increased retention of water and sodium, and this in turn will affect the fluid balance, and that is how we have to approach the fluid management. That is the main point of interest in this topic that I have to say. So next thing, we can look at the causes of the pediatric heart failure. We have the congenital heart disease, volume overload, left to right shunt, VSD, PDA.
Just a minute,
and
just a
also-
minute. Somnath,
Hello.
can you mute Professor Datta?
লোগো দিয়েছে লোগো এটা তো লোগো কিছু দেয়নি এটা কি মজা আমাদের অফিস
Yes, Somnath, please. Yes, please continue. Sananda,
Yes,
please
sir.
continue.
So, yes, sir. So congenital heart disease, we can just see some examples like the volume overload lesions are the VSD PDA with the left to right shunts, and also the AV semilunar valve insufficiency AR also, and in pressure overloaded lesions are the severe AS, coarctation of aorta, severe PS. Also comes the complex heart diseases like the hypoplastic heart disease and CCTGA. Cardiomyopathy is a different pathology, not our topic of interest today. However, just mentioning it, like primary DCM or RCMP or HCM, and secondary is ischemic, toxic, infective, infiltrative, or ethmogenic cardiomyopathy. So next we come, like, how will the patient present to us in congestive heart failure? So they can present as a compensated or they can present in decompensated. Now, compensated patient, why will they present to us? They will generally be presented if they will have been posted for surgery the next day, like that. So what happens in compensated heart failure is that congestion will be there, but the perfusion will be normal. And the decompensated patient obviously is the emergency patient in whom we have to manage the fluid and check all those, and we have to manage the heart failure. Those patients will come with congestion, and also the perfusion will be decreased. So that is a basic difference. Now, compensated failure, we don't need to manage fluid as such. We will go for the enteral fluid therapy, fluid route, that will be your strategy, because we don't want to overload the patient with any fluids. And for decompensated, the management comes in the following slides. Now, for the clinical signs of congestion, there will be tachypnea, tachycardia, hepatomegaly. These three are mainly seen in very young infants and neonates. Then there will be peripheral edema, raised JVP, we can see mainly in some older children. Rales and ascites can be can be seen only if there is a very huge amount of congestion. Then comes the evidence for low perfusion. What are the evidence for low perfusion? They are the narrow pulse pressure, cool extremities, mental confusion will be there, low BP, hypotension, and the worsening renal function. So next, there is an approach to the child with congestive heart failure. How do we approach it? Like management approach is acute compensated heart failure for a known cause. Like known cause means, as we are discussing about congenital heart disease, obviously we know that the patient is coming with a structural heart lesion. So that is a known cause. So we will go with diuretics, inotropes, vasodilators for the hemodynamic recovery. After that, etiology-based management, like if it's a CHD, as in our case, we will go for surgical correction, and we will then keep the patient on medical therapy and follow up. And if it is due to the duct dependent CHD, we will go for PG infusion, prostaglandin infusion, and ductal stenting. And extra cardiac causes we have to manage accordingly. Now, coming to our goals in fluid therapy, we have to just maintain the adequate circulating volume and tissue perfusion, and we also have to avoid fluid overload. Because as we have mentioned, this is actually a condition where there will be retention of fluid and sodium. Sodium and fluid retention. So we have to be very careful about how much fluid we give, so as to avoid the fluid overload and further decompensating the patient. So our fluid strategy will be mainly restrictive, and we should prefer the enteral route, like in compensated heart failure we had done. But as we all know, when the acute decompensated heart failure patient presents, we obviously can't go to enteral route first half. First up, we have to resuscitate the patient, and then we have to put them on maintenance, and then we can go to the enteral route. But as early as possible, we should be able to shift it. So what about the initial resuscitation? As we all know, in all forms of cardiogenic shock, it is recommended that we give 5 to 10 ml per kg of fluid bolus over 30 minutes, check for fluid responsiveness. But as it is a case of congestive heart failure, it has been recommended that we avoid the fluid boluses in all cases of congestive cardiac failure, whatever may be the underlying cause of it. So we avoid the fluid bolus. We will optimize the preload and optimize the afterload with medications like diuretics and fluid restriction for preload, and for afterload we will optimize it with vasodilators and inotropes. That has been recommended recently. So what will be the dosage of, now coming to the maintenance therapy? The dosage of maintenance therapy should be 50 to 60% of the normal fluid requirements of a normal patient, normal maintenance fluid requirements, that we calculate by the caloric expenditure method or the holiday cigar method. As it has been extensively discussed previously also, I am just giving the chart. So holiday cigar method, we just give 50 to 60%. Now what we have to remember is that the total amount of maintenance fluid calculated should also include the total volume of other fluids that are being given as carriers for drug administration. There should not be any extra fluid going into the patient, that because that will decompensate the patient further. Now, what should be the composition of the maintenance fluid? As we all know, isotonic fluids will be the best, and also we should give balanced crystalloid solution. We know that most common isotonic fluid that we use is normal saline, but normal saline is actually an unbalanced solution. It will lead to hyperchloremic acidosis in patients, especially those patients who are posted for surgery. We should not at all try to give this fluid because it will lead to renal compromise after surgery. So the best solution will be ringal lactate along with 5% dextrose. We can also, for neonates and young infants who have very high requirement of glucose, as they cannot maintain blood glucose, we can also give up to 10% of dextrose solution with ringal lactate. Also, plasmalite A is a good choice for maintenance fluid. So as I said earlier, this slide is about the NS being an unbalanced crystalloid. So moving on to the next slide, how will we monitor the fluid status and intravascular volume? So there are three types of monitors, that is clinical parameter, laboratory, and the surrogates of oxygen delivery. So coming to the clinical parameters, there will be skin temperature, arm extremities, adequacy and volume of the peripheral pulses we have to check. CRT should be less, capillary refill time should be less than 2 seconds. Vitals like heart rate, blood pressure, and the oxygen saturation we should check. Urine output should be checked daily body weight, lung auscultation should be done, and mental status examination should be done to check for the adequacy of volume and fluid status. What are the laboratory parameters? We should do electrolytes, we should do serum creatinine, we should do hematocrit and urine analysis. And coming to the surrogates of oxygen delivery, that is the central venous oxygen saturation of greater than 70% marks that adequate means volume intravascular volume is there. So SVO2 greater than 70% in two ventricle physiology, and it should be greater than 55% in single ventricle physiology. Also, serum lactate levels should be less than 2 micromoles per liter, millimoles per liter. Now coming to the brief overview of the CHD management, as we all know, we will get to face many CHDs coming to us, and maximum of the management is surgery. I have just given an overview of what surgery, which are emergency surgery, and which are like planned surgery that can be done. So this is just a brief overview. Of course, we all know that surgical management in most of the cases of CHD is required. So I will just briefly tell about the outline of fluid strategy in cardiac surgery patients, those who are posted for surgery, what should be the perioperative fluid and what should be the post-operative fluids. Basically, cardiac patients, they going for surgery, perioperative or day of surgery, they will need half, that is 500 ml per meter square per day of fluid. That is 50% of maintenance compared to the non-surgical patients on the perioperative day of surgery. On post-operative day 1, 2, 3, and 4, we will gradually increase the fluid volume, and on day 4, we will achieve the maximum that we give to normal patients. And these are about for the patients with undergoing surgery with cardiopulmonary bypass, because we know those patients who are undergoing surgery with cardiopulmonary bypass, those patients will have a tendency of fluid overload. So we have to manage accordingly like that. And those patients who are without undergoing surgery without cardiopulmonary bypass, like the Blalock-Taussig shunt and the PDA ligation quadrilateral aorta, we can give like 60 on the day of surgery, 60 ml per kg per day, then 70, 80, 90 to 100. We'll achieve it over 3 to 4 days. Full maintenance requirement will be achieved over 3 to 5 days in most of the stable infants. So the take-home message from here is that we should try to shift the patient to enteral as early as possible. Fluid restriction should be the key, and balanced isotonic solution is to be preferred. So that is all from my presentation point. So, sir, thank you for giving me the opportunity. And if there are any questions.
Thank
Hello,
you,
sir.
Dr. Mojumdar, for your
Yes, sir.
presentation, very lucid presentation. I think, is there any question? If there are questions, so we can take. Choice of inotrope in CCF if underlying cause is unknown or doubtful.
Sir,
Dr. Mojumdar?
choice of inotrope in CCF underlying cause unknown or doubtful, it doesn't matter. Actually, CCF we have to go for dobutamine, which is the choice of inotrope in CCF. That is the thing, sir. Dobutamine
Use
is
of
the first choice.
digitalization in congestive heart failure.
Now, one thing is
Digitalization
that just I want to add for the patient inotrope. If the you need to note that if the patient have just Sananda has made, the patient is very hemodynamically unstable, so low BP with heart failure, you have to start with inotrope like the epinephrine, the low dose 0.05 microgram, or if the severely hypotensive, we can sometimes use norepinephrine with 0.05. Then gradually, whenever your blood pressure is reaching to 5th centile, add dobutamine. Otherwise, you can add the milrinone if your blood pressure is maintained. So if the blood pressure is maintained, so you need not to start with epinephrine or norepinephrine. You can go directly to milrinone or dobutamine.
Actually, Dr. Bagga has also told this. So what is the use of digitalization in congestive heart failure? Sananda, can you listen?
Hello.
To
Hello.
use of digitalis in congestive cardiac
Hello,
failure?
sir. Am I audible, sir?
Yeah,
Hello.
yeah.
Yes.
Hello, sir. Hello, sir.
Yes, you are
Sir.
audible. You are audible.
Hello.
The question is use of digitalis in congestive cardiac failure.
Hello.
Means the
Sir,
net
can I?
issue.
Okay. So I
You
think
can-
it is not the main issue, but it is this role of digitalization is very narrow now. In few conditions with the left to right shunt with
Hello.
refractory heart failure, in that case you can use the digitalization with patient with severe tachycardia. So otherwise it is very narrow use now. Okay. Any other question?
Fluid management in congenital heart block.
Congenital heart block, I don't know what you want to ask. So the congenital heart block, if the patient, it depends upon the patient hemodynamics and the patient status. If the patient is severe, third degree heart block with the
I
patient
think if the
hemodynamically
mother is
unstable.
suffering from the lupus,
Okay.
then the baby may present with congenital heart block. So in that case, what fluid you will choose? It depends upon when you were getting, na?
Yes, yes. And also the hemodynamic status. If the patient is able to take orally, not very symptomatic or hemodynamic stable, then oral feeding can be allowed. And otherwise, if the patient is in heart failure due to the heart block, then you need fluids and you have to titrate, start the 50 to 60% if the patient is not in shock, and then titrate the fluid according to
Hello,
the patient.
sir. Hello.
Yes,
In
you
a
are audible.
child,
Yes, sir. Just the connections are just cut once. That's why, sir.
Okay,
The
now you
problem.
are audible now. So next question
Yes, sir.
after
the next
Swapon Rai.
question for Dr. Majumdar. In a child presenting with hypotension and pulmonary edema, can we give
Yes, sir.
fluid boluses?
No, actually, basically, hypotension and pulmonary edema is a very complex situation. Pulmonary edema, cannot give fluid boluses, but we have to just monitor what is the intravascular means the fluid dynamics that we monitor, the fluid status that we monitor by the dynamic and the static variables that we have to monitor and then assess for fluid responsiveness. We can give a small bolus and check if the patient is fluid responsive. Gently, we can give 5 ml per kg and then check for fluid responsiveness. If it is responsive, then we can give. Otherwise, it is of no use, because in pulmonary edema, it will further aggravate it. And also the thing is that if there is severe pulmonary edema, we go for mechanical ventilation of the patient. That will be a more better approach for these patients.
So in
Just
any
want
other
to add-
comments from Mihir on Sumantra?
Yes, one thing is that this is a very critical situation. So in this case, regarding the respiratory supports, along with that, you have to need the focus. The bedside, the focus ultrasound will be helpful. So what is the current IVC status? So it is the lung water content. So in the basis of the B line, so if the already lung water content is very high and your IVC is dilated, patient, and you can see in the just eyeballing, you can see the myocardial contractility is poor. In that case, the fluid bolus further will deteriorate. So you will avoid and will titrate the ionotrope in that case. But if you have a scope that the on the basis of your focus that you can give the low volume of bolus like 5 ml or 10 ml per kg slow bolus based on your IVC collapsibility and the lung B lines, then you can give very slow over 30 minutes to 1 hour.
Thank you. Which ionotrope is better, Mindinone or dobutamine in CCF?
There is no head-to-head trial on those two, based on the dobutamine and the milrinone. Milrinone, I think if the patient is initially hypotensive, we try to avoid milrinone because it has a vasodilatory effect is more than the dobutamine. So patient may precipitate to hypotension. Otherwise, the ionotropic, the lucitropic effect and the ionotropic is better theoretically for the milrinone. But there is no head-to-head trial based on the how you are monitoring and what is your patient status at that moment.
And the price also, Mindinone is very costly. Is it same? No. And both hypo and hyperkalemia causes periodic paralysis. What is cause?
Sir, answered already. Answered in chat box, sir.
Oh, you have answered. Okay. So I think
Sir,
other
in
questions
QA,
you can answer. Shananda and
Yes, sir.
my whole panelist, you can answer in the chat box. So now
Okay, sir.
we will come to the end of the session. Now it will be the quiz competition. So I'll hand it over to our dynamic Dr. Rohit Bhomik. So he will be the conductor and the quiz master. And I am just requesting you, the quiz master decision is final. Okay. And Rohit will already has posted in the group what are the rules and regulations. Again, I would request Dr. Rohit Bhomik to tell and gist how do they participate. And now the screen is yours, Rohit.
Thank you, sir, for this opportunity. So as we already sent in your group the PDF format, So what you have to do, I will share a link after some time. So you open the link from your any other devices. And that time you may or may not be present in the Zoom. You can leave the Zoom. You click from the mobile and automatically questions will be uploaded. So don't click any other thing. I'll just go through a short PowerPoint at this moment, just 2 minutes PowerPoint. So is it visible now?
Yes.
Yeah. So if you see, it will come in a Mentimeter. So first step is this screen will be there in your laptop or computer. So you click, may require code if you join through laptop. So code also I will share. Code already being shared, but I will share again. Step 2, you will see this kind of some cartoons. It may come as a fox or whatsoever, like bus. You put your name. I'm requesting put your full name as you registered in the CME, because the sir will check the final. Once the final result comes, our judges will check that the names are matching or not. This is mainly to respect whoever has properly registered. So once your name will come, it will ask us a join the quiz. So I did it. So my name is there. Once I click join the quiz, get ready to play Rohit Bhomik. So your name will be displayed and you are ready to play. Here it is written as a question 5 by 5, but in this case your will be 25 by 5. So we have 25 questions. After you join, it will show this reload or join another quiz. Don't press anything. If you press join another quiz, you will be out from this. Without your knowledge, you will be out from this app. So don't press anything. Automatically question will come to your screen. If at all you pressed or you are lagging because of your network issue, you can click this reload. But unfortunately, by the time 1 or 2 questions may go. Next is, once you start, suppose all of you are logged, I am starting the quiz, it will show as this: answer first to get more points. Within few seconds, the question will come. Like here, the question is, which Indian song recently won Oscar award? Okay, and it will come, the number will come as a 5. So 5, 4, 3, 2, 1. 5 seconds, you can see the question, you can prepare your brain and get it ready, and then the options will come. So after that, it will come like that, some option like XYZ option. Remember, if you are correct, you click on this. This question is Eiffel Tower is situated in. So if you correctly click on this, your score can vary from 1000 points to 500 points. If you just click, it can be fastest finger first. So the fastest person will get 1000 points, and the respective subsequently, and the last person will get 500 points. This is valid for only correct answer. If you click somewhere else, anyway, you will be getting 0. So if you click the correct answer or whatever the option, suppose you are not able to vote in the time, it may show it you did not vote in time. If you click wrong answer, it will show as a wrong answer. Sometimes that it will show as a loading results, or if you are correct, it will show as a correct answer. So let's see how you did. So it may show as a correct answer. It will show that within this seconds you have answered, or if you answered it wrongly, it will show as a wrong answer. So hope I am clear in this. So the options will be either right, or you can leave it. You have not voted like that. So try to avoid any clicking except the question answer. It will automatically come to your screen. Thank you.
I have got only one request to all my enlightened panelists. You are not entitled to enter into this competition. Okay, you can enjoy, but you will not be able to enter into the competition.
So anybody, any questions from the attendees? So I have stopped sharing. Any doubts? From
them 2 minutes. If they have any queries, they can post in the chat box. In between, Kalpana madam, if you want to say something. I think the proof.
The only I can say all the speakers are brilliant and excellent. I have also learned many things, recapitulated many things. I have also many doubts also, many things to be cleared in future also. So excellent presentation by all the faculties, and in time they finished. Excellent moderation by Dr. Mihi, Shugantru, Dr. Kaustav, Dr. Shapun, and Dr. I think Atunwan Dr. Champu Das was also there. And excellent response by the participants. I'm really happy to see their enthusiasm and the questions interacting with the faculties. So this is the thing we will like to see in future also. And I'll request all the participants to again participate and register in the next workshop. That will be very interesting and very wonderful. I think we'll learn a lot. So I think this is much from my side, and all the best for your future. Thank you. Over to Dr. Mihi.
Okay, ma'am.
Okay.
So any questions came till now, you can post in the WhatsApp also. Once you start, you may not be able to ask anything because then time will go on. So the link I have shared, if at all somebody is logging through laptop, they may ask this code. No need to down any app, anything. You just click on this from your mobile. You can keep the Zoom on from the other device or tab or whatsoever. It is handy to do from your mobile phone. So shall we start, sir and madam?
I think you start.
Yeah.
There's no queries.
So, Mihi sir, you can clarify if any problems are happening. So I am waiting. Players are joining. So till now 12:54.
Okay. Should I am joining also there. If there is any problem, then I
Yeah,
can
yeah.
know. Okay.
I am also joining. I am also joining, but I won't respond to anything, and no panelist also.
No, sir, you can respond. The results will show that it will rank will come and we can identify.
For the clarity and the transparency, we should not.
Yeah, so we are just waiting. 68 players are ready. Many players are joining. I think continuously it is coming. 73, 74.
98 attendees are there. So I think all of them should join.
So it is
Yes,
fluctuating.
request you all to join. It will be fun. Don't get it as a judgment.
Many players are joining.
Actually, the panelist may know the answer, so it's better not to enter into this competition.
Okay, sir.
No answer will be better choice.
Still it is increasing, sir. It is 80, 82.
Wait for 5 minutes. Wait for
So
5
96 now. Total attendees are 96.
Okay. No, maybe people are leaving from Zoom.
Yeah, they are leaving.
You have to give that time, no? You have to give that time.
Oh, somebody is asking for link also. Okay, fine. In the WhatsApp group, they are asking for the link. Okay. No problem.
But you didn't ask me the code. I logged in.
No, if you log, sir, from mobile,
laptop.
it won't ask. Straightforward, it will take to.
Join from his laptop, but he didn't ask.
Yeah. Then you directly. So people are asking for code link. Yes. '86, 85. Continuously, people are joining actually.
But I can see the number.
Yeah. 89 now.
এটা কি মানে জুমেতে শেয়ার করা যাবে? জুমেতে কেউ দেখতে পাচ্ছে না কিন্তু।
জুমে হ্যাঁ করা যাবে।
আচ্ছা, সেটা আমি জানিয়ে রাখলাম আর কি, সেই জন্য
এই করে দিচ্ছি। হ্যাঁ হ্যাঁ করা যাবে।
ওকে, তাতে কোনো প্রবলেম হবে না তো,
রোহিত,
মানে
না
কন্ডাক্ট করতে কোনো
রোহিত,
প্রবলেম হবে না তো?
হ্যাঁ স্যার এই যে জয়েন দিয়ে দিলাম স্যার। না না
Rohit,
অসুবিধা হবে না। বলুন স্যার।
again post the link. Dr. Sujoy Chaudhary asking for the link in the chat box.
চ্যাট বক্স, আচ্ছা ঠিক আছে স্যার।
Again, posting in the chat box.
ওকে
এটা তো আগের স্লাইড, এটাকে তো স্টপ শেয়ার, হ্যাঁ স্টপ শেয়ার।
করে দিয়েছি স্যার। এই যে আবার মিহির স্যার করে দিয়েছে চ্যাট বক্সে। কটায় শুরু করবো স্যার? এখনো 92, আরো বাড়ছে 93, 94।
So give some time because there may be they are coming from.
But the attendance is 89. শুধু
কিন্তু না না অনেকেই স্যার বেরিয়ে গিয়ে
They
many
may
people are
have
leaving.
leaving the Zoom, they are joining there.
ওকে,
94.
I
Once
think
it
when it
becomes 100,
started,
we'll start.
Okay. Sir, is my screen is visible through Zoom?
no.
Okay.
Hmm.
Okay sir, that will share. Now sir.
Yes.
Rohit has started. Yes.
So
Yes, I think Rohit, how many now it is participants, number of participants?
it is visible sir to Zoom 95.
Yes, visible. I think
So
we can start.
yeah. So the first question, answer first. So first question is coming. Which statement among the following is correct? You have to answer the correct option. So the correct answer is rate of change of sodium is very crucial while treating dysnatremia. That we have discussed yesterday many times. So second question is coming. We are waiting for the players to get. Second question is now on your screen. Just wait. Yeah. Which statement among the following is false? You have to identify the false statement, wrong statement. So this question is also over. We are coming. Third question is coming. People are joining slowly. Yeah. So almost 92 players are ready. Third question is on your screen. So third question also many people answered. The right answer is it is CSW. Fourth question now. So everyone has voted. Very nice. So the correct answer is here, increase urinary calcium excretion. Fifth question will come. So fifth question is now on. So voting is over. So we are going to sixth question.
The answer.
Answers is displayed already. We'll,
Balance all solutions.
yeah. So 92 players are ready. Questions is now visible. So overhydration was the correct answer. Almost 58% gave the right answer. Next question. We are waiting for the players. Everybody join. Seventh question is on your screen now. So we want target urine output more than 1 ml per kg per hour. Yesterday, nicely discussed by our speakers. Next question. All players join. So fluid for Sam, many gave correct answer. Question number 9. Players are ready. Many answer correctly. Question number 10. We are waiting for the players. 90, 92. Question number 10 is now on your screen. It is severe dehydration. Question number 11. Everyone is ready now. Question number 11. Many correct answer for this.
Good.
Question number 12 is ready. All people are joined. Many answer rightly. This is albumin. Question number 13.
Good. 59 correct answers.
Yeah. Question number 14. Many correct answer. Question number 15.
Many
Almost
right
everyone.
answer. Yes, 69 right answers. Excellent.
Question number 16. Again, many correct answers. Question number 17.
Good.
Good. So all being discussed during our discussions and presentations. Next question.
Forty-seven correct.
Few more questions. We are almost finishing. Question number 19.
Good.
Mhm.
Excellent. Very nice. Everyone voted.
Everyone did.
Question number 21.
21.
92. All are ready.
Good.
Many correct. Today's teaching only.
Yes.
$22. Perfect. Many correct. 23rd.
Good.
2 more questions.
Almost done.
Almost done. No technical glitches, I think. Everybody is able to join.
Excellent. Yes.
24th.
Good.
55.
And the
Last
final one.
question. Final one.
Good.
60,
So-
64, 54.
54.
64.
So now the result will be shown.
Excellent,
To,
Rohit.
thank you.
Well done.
No.
আমার একটা query আছে।
Well done.
Technically perfect.
Thank you, sir.
আমার
What
একটা question আছে।
moderate dehydration, ma'am?
না না আমার একটা কোশ্চেন আছে মিহিরের কাছে।
হ্যাঁ।
কমপ্লিট হয়ে গেছে তো তোমাদের কুইজ তাহলে
হ্যাঁ
জিজ্ঞেস
হ্যাঁ রেজাল্ট আসছে
হ্যাঁ।
ম্যাম।
না
Result.
মিহিরের কাছে প্রশ্ন কোয়েরি আছে এই রোহিত ভৌমিকে কোথাতে খুঁজে বার করলে ওয়ান্ডারফুল
No, no, Rohit is
I'm
very
NRS.
much known.
দারুণ
Rohit
করেছো
is very much known. যখন আমাদের লকডাউন পিরিয়ড হয়েছিল, Rohit was most interactive.
আচ্ছা
And he was given the chance. He was given the chance to participate for his excellent presence and in questions. Probably he was selected from CIP.
Yeah,
Is
yes,
that
sir. Yes, sir. Yes, sir.
we are selected from CIP? Yes.
Rohit is same time intensivist and pediatric nephrologist. He has training as both. He is-
Actually, I had seen him more than 200, 250 times.
Not only the nephrologist and intensivist, he also great techno expert.
So this is the result, ma'am.
Exactly.
Result is coming. So no tiebreakers.
Yeah.
Shreya Rai Chaudhary is the first one.
Okay,
1967.
congratulations, Shreya.
Congratulations, Dr.
Yeah.
Shreya.
Congrats.
So we have to check it that registration and all, sir. Second is Brotesh Das.
Brotesh, congratulations from Medical
Rohit,
College.
congratulations.
And Shreya, just write in your chat box from which college you are in.
Your introduction.
Introduction.
And
SRO
third,
chair.
Shreya,
Third, you know,
please write
Medical
your
College.
present designation and where are you now?
and third is Narayan Santuka.
Prasad.
Good.
Narayan,
Congratulations, Dr. Narayan.
we cannot see it, no?
Sir,
Can
the
you display
screen.
the name, Rohit?
Also, Narayan also request you to also write your present as a designation and that as affiliation.
Rohit,
Sir,
please show the second
Rohit.
one. Please show the second one and third one.
Pratesh Das.
Medical college too.
Can you show
Pratesh
the
also
point?
write your.
Yeah, I'm in WhatsApp group. I am sharing because I have to hold this for some time. In
Okay,
the
okay.
and snapshot also.
Kotok. Oh,
Oh, Dr. Narayan as the
SCPMC.
senior resident SCPMCH Kotok. Excellent. And Rotesh
Oh.
also write your name and the affiliation and your designation.
And Shreya is
Shreya Rai
from
Chaudhary.
Shreya Rai
CSS.
Chaudhary is
SRS.
senior resident
CSS.
CSS, Kolkata.
Okay.
Ranjan Seva Sadhan.
So all are registered, sir. Then I have to close. If they are not registered, then the Anand and the
Now
subsequent.
keep your I think Somnath, just check the once your Excel sheet for Shreya, Rotesh and Dr. Narayan.
Yes. Rotesh has already been introduced. So the first prize will be 3,000 rupees. It will reach
Wow.
in time. Second prize
Only in
will
the
go to
registered
Rotesh.
committee.
It will 2,000 and the third prize is the 1,000. So this is the WAP initiative with the active role with our president, Professor Kalpana Datta, and very active Dr. Mihir Sarkar, Dr. Sumanta Raut, and Dr. Rohit Bhaumik, and all the faculties, those who have joined. And thank you.
So
Thank
Dr.
you very
Shapun,
much.
our senior member has joined, sir, Dr. Shamir
Yes,
sir.
Somita.
Request him to say a few words.
Good evening, sir.
Somita, Dibbendu.
Bolun.
Oh, just to inform that all three are registered, so there is no issue on that, and so we can go ahead with the result.
Before that, I will request that Somnath, please collect either the QR code of their Phone Pay, Google Pay, or something like that, so that we can transfer the money. These three, the Shreya, Rotesh, and the Narayan, please share your QR code to Somnath in the group so that we can send you the money immediately.
And request Dr. Shobiranjan Das sir to say a few words.
Somita, please.
Excellent presentations, and like Professor Datto, I can say that I learned a lot this evening, and I'm amazed in the technical and intelligence, both combination of intelligence and technical ability of Dr. Bhaumik. I would like to know where he is now presently, because I am finding his name in like Professor Shapun said, from the lockdown period where he was awarded for attending
in Kollani. He is in AIMS
Oh,
Kollani.
you are in AIMS Kollani. Thank you. Congratulations.
Thank you, sir.
Big round of applause for you for so excellent.
Thank you.
Thank you all, Professor Mihir Sarkar, Dr. Sumanta Raut, and
Thank you, sir.
Rohit Bhaumik, and all others who have done this very nicely. And also thanks goes to the WAP office staff who had done it properly without any glitch. We hadn't any problem while watching this wonderful session. Thank you all.
Dr. Dibbendu Rai Chaudhary, Vice President of the West Bengal Academy of Pediatrics.
Unmute koro, video on koro.
No video on. Excellent workshop. Excellent, unique. First of its kind in West Bengal. I have never seen this type of workshop. And lastly, the quiz is excellent, mesmerized. A big clap for Rohit. Okay, Rohit, well done.
Sir,
very
everybody,
well.
sir, send questions, sir. The questions are full of collection, like all faculties are sent the questions. I have to.
But unique presentation. Okay, a big clap for you. That's all. Thank you all. Thank you.
So
So Mihir,
special.
I
Mihir,
think
please.
Dr. Shapun will get the vote of thanks.
Mihir, please.
Okay.
Yes, so
You,
I
you
think
have
as
taken
Madam
lot of
has said,
pain for this.
no, I think my job was easy because Sumanto and Rohit is there. They are two most
Thank you, sir.
expert, and when they are there, that is my job is easy. So the only thing I have to do is the just coordination with the Somnathda and between them. And Somnathda also done a very excellent job because even on the last day and the last moment, there are many requests for registration, and Somnathda has just on a cool head has managed everything.
Thank you, sir. Thank you, sir.
And
Any
also,
feedback or from the participant in chat box or any chance to improving us from the participant in the chat box?
Yes. Yes, so we'll request also in the WhatsApp, we'll write them to their feedback, to give their feedback, because we'll be doing this, as Madam has already told, we'll be doing such kind of programs even in the subsequent months with the very common and practical topics related to both general practitioners, related to residents, who will be helpful for both of them. So and also the thanks for all the young faculties who have prepared and who have worked and delivered their lectures and prepared their talks and then delivered very nicely. So special thanks to them. So and also as a whole from the West Bengal IAP, our special gratitude to two stalwarts, Professor Arvind Bagga sir and the Professor Jayashree Muralidharan madam, because they started in such a way in the first 2 days, and there was an excellent crystal clear talk and the long QA sessions, and everything was clear, every doubts are cleared and by them. So special thanks. And also the thanks to the delegates because their enthusiasm and their interest has made us more active to do, and we are also now more interested and we are more motivated to do better programs in coming days. So over to you, Shapun sir, to tell your final words.
Before I talk, I just want to give a big thanks to Sumanto. Sumanto, you want to say anything?
No, sir. It's my pleasure, sir, to work for WAP and the whole dignitaries of like this. And my thanks to all the attendees who have made this program successful. Thank you, sir.
So actually, these 3 days I was glued to the chair. In fact, I learned a lot from all the faculties and the mentors. And really, it was amazing sessions all throughout. And I must thank our leader who is leading in front, Professor Kalpana Datta. It is a hard brainchild to start this type of workshop. Thank you, madam. And obviously, I must thank all the OBs and the EBs because I have requested to that I have seen Somrida, Champakda, even Amita and Atanu has joined this session. So this is the group initiative. I must thank all the faculties, particularly Professor Bagga, Professor Muralidharan, Jayashree Muralidharan for the first 2 days. And the last days has been rocked by Rohit. Again, I don't know how to praise you. And overall, whole day, these 3 days were being taken up by Sumantro and Professor Mihir Sarkar. And all the faculties, I'm really grateful to you that you have agreed to deliver your talk and share your expertise. And Somnathda, if I don't mention about Somnathda, it will be I be guilty. Every time I request here at the early morning or at the late night, he is always there. And he was apprehended about that quiz, but with that Rohit in the hand, we can do anything. So I'll just request, don't leave the WhatsApp group. We will try to give you the YouTube link within 3 days. Somnathda will be working on it because we want to help you, but we cannot give the PPT because that needs permission and many may not agree to give the PPT, but we'll give the YouTube link. The whole events of the 3 days has been recorded and we'll share you within 2 to 3 days. And in future, WAP is going to organize more such. Possibly our next workshop will be on the ECG and the X-rays of the congenital heart disease or the cardiac disease. So I hope you will join again and participate actively. So we are determined that WAP will be coming up with the flying colors in coming days to help you all the residents and even the practicing pediatrician alike. And thank you all. And I think
Can we speak make our video one for once so that
So
we can
all the
satisfy?
faculties, please open your video for
If
just
possible,
once.
if feasible.
we
Yes,
will
yes.
take the photographs.
Divyendu is wanted.
Divyendu to হাসছে already, so ma'am, no problem.
Divyendu,
যদি possible আছে।
Dr. Nupur,
সোমনাথ দা একটু ছবিটা নিয়ে নেবেন।
সুমন্ত্র দুটো আছে সুমন্ত্র।
স্যার একটা বেরিয়ে যাচ্ছি, আমি একটা বেরিয়ে যাচ্ছি।
সত্যব্রত।
Thank you, Devlina. Thank you, Dr. Aditi. Thank you, Dr. Nupur.
ফটোটা কে নিল?
Satyabrat. So I think Sumo এ নেবে সোমনাথ দা।
আমি ক্যাপচার করে নিচ্ছি স্যার।
ফটোটা নিয়ে নিন।
হয়ে গেছে।
Okay, okay. So, Dr. Dattro, please conclude the session.
Yes, everything, all of it. We're really happy, and today I'm really feeling very happy and very satisfied at the end of the third day. It was very satisfactory session for the last 3 days, and because of all of youngsters, I can see all the energetic, dynamic, and academic youngsters. So I'm really hopeful in our future. WOP and the West Bengal will stand some position in the country also in academic stand. So with this enthusiasm, I'm really happy to see the future. Thank you all. And we need more cooperation from all the faculties and all other faculties who are not in this platform. So we'll invite all the faculties and the participants to make it successful in the future also. Thank you all.
Thank you.
Thank you, madam. Okay,
Thank
good
you.
night.
Good night.
Thank you. Good night. Good night. All the best.
Good night.
গ্রুপে পোস্ট করে দিয়েছি।
Okay,
Okay.
thank you.
করেছেন।
Thank you সোমনাথ দা,
Post
প্রচুর
করে।
হেল্প করলেন 3 দিন ধরে, প্রচুর হেল্প করেছেন।
না না,
হ্যাঁ।
রোহিতকে শোনো না, সুমন্ত্র,
Yes sir,
রোহিতকে আমাদের
পে করে দেওয়া উচিত স্যার, রাইট।
ওই কম্পিউটার এন্ড ওয়েবে নিয়ে নাও,
হ্যাঁ
ঠিক আছে? ওকে
হ্যাঁ।
আমাদের লাগবে।
হ্যাঁ,
ওকে আমাদের কম্পিউটার এন্ড ওয়েবে একটা ডিভিশন করে দিচ্ছি, ওকে নিয়ে
ঠিক
নাও,
স্যার,
বিকজ
right.
আমাদের ওকে শোকেস করা উচিত। ইজ
হুম, হুম।
ট্যালেন্টেড, লাইক
হুম।
কোনো বিচ নেই, কিচ্ছু
স্যার,
নেই, সুন্দরভাবে করেছে।
আর টেক্সটই স্যার, মানে প্রথম থেকে বলেছিল যে ম্যানেজ করে দেবো একাই, চিন্তা নেই।
হ্যাঁ হ্যাঁ, টেক্সাবি মানে দারুণ।
হ্যাঁ,
মানে
ও একবার নিজেও বলেনি কিন্তু যে টাকাটার জন্য, আমি মাসে থেকে জিজ্ঞেস করলাম যে তুমি এটা
না,
পেলে
না,
কি
টাকা
করে
দিয়ে
দিই
দেওয়া হবে,
প্রজেক্টের জন্য।
সোমনাথ
হ্যাঁ,
দা।
না ও নিজে থেকেও বলেনি, আমরা জিজ্ঞেস করে তবে বলবো, মানে ও নিজে থেকেই করে দিচ্ছিল।
রোহিতকে ওর এই অ্যাপটাকে ওকে পে করতে
ওটা
হবে।
বোধহয় 1200 না 1500 সামথিং লেগেছে একটা কিছু ফর 1 মান্থ।
রোহিত বাবুকে আমাকে এটা পাঠিয়ে দিতে বলবেন, বিলটা
হ্যাঁ,
পাঠিয়ে
হ্যাঁ,
দিতে বলবেন,
সুমন্ত্র,
এন্ড
হ্যাঁ, স্যার।
ব্যাংক ডিটেইলসটা পাঠিয়ে দিতে
গ্রুপে
বলবেন।
একটা পোস্ট করো, দ্য ফার্স্ট শ্রেয়া, সেকেন্ড হচ্ছে ব্রতেশ, এন্ড থার্ড হচ্ছে নারায়ণ। ইউ
Yes.
জাস্ট গিভ ইউর কন্টাক্ট নাম্বার, আর এখন তো ফোন পে, গুগল পে যদি কোনো লিংক দিয়ে দেয় তো ওইখান থেকে দিয়ে দেয় ভালো, ঠিক আছে?
আমরা এনইএফটি করে দেবো দাদা, স্বপন দা, আমরা এনইএফটি করে দেবো, নেফট করে দেবো, এনইএফটি করে দেবো। ওরা ব্যাংক
নাহলে NEFT করে দিতে হবে।
আমাদের তো অ্যাকাউন্টে টাকা ঢুকেই গেছে এই সেমিনারের জন্য, অনেক টাকা ঢুকে গেছে, আমরা ওখান থেকে এনইএফটি করে দেবো।
তাহলে সুমন্ত তাই করে দাও যে সেন্ড ইউর ডিটেলস, আর রোহিতের থেকেও নিয়ে নাও, কারণ আমাদের এটা তো মানে অডিটেড হয়, ফলে ওই এনইএফটি করলে আমার মনে হয় সুবিধা হবে আমাদের থেকে।
এক্স্যাক্টলি একটা কাগজ তো আমার লাগবে, এই অ্যামাউন্টটা ট্রান্সফার।
তাহলে কি ব্যাংক ডিটেইলস দিতে বলবো, তাই তো?
হ্যাঁ হ্যাঁ,
অনলি ব্যাংক ডিটেইলসটা দিতে বলতে
তাহলে পার্সোনালি পাঠাতে বলি, হোয়াটসঅ্যাপ গ্রুপে নয়, পার্সোনালি টু সোমনাথ দাস নম্বর ও আমার নম্বরে
না
একটা
না,
হোয়াটসঅ্যাপ
সোমনাথ
করে
দা
দিই।
না, গ্রুপেই পোস্ট করুক না, গ্রুপেই পোস্ট করুক।
গ্রুপে কেন
ব্যাংক ডিটেইলসটা স্যার গ্রুপে দরকার নেই।
তাহলে এক কাজ করো, এটা তুমি
আমাকে
তোমার এতে নিয়ে নাও।
হ্যাঁ
তোমার
হ্যাঁ,
এতে নিয়ে নাও।
তুমি পার্সোনালি নিয়ে নাও, তুমি আমায় পাঠিয়ে দেবে,
ঠিক
আমি
আছে,
সুশান্তকে দিয়ে দেবো, একটা ভাউচার করে দেবো, করে দিয়ে আমি এনইএফটি করে দেবো।
ওকে, দ্যাটস ফাইন।
এর থেকেও নিয়ে নেবে, তাহলে রোহিতের থেকেও নিয়ে নাও।
হ্যাঁ, রোহিত
হ্যাঁ,
একটা ওর খরচার একটা ওখান থেকে একটা ইনভয়েস বেরোয়, ওই ইনভয়েসটা আর রোহিতদার পুরো ব্যাংক ডিটেইলসটা পাঠালে আমি নেফট করে দেবো।
ওকে, দ্যাটস ফাইন।
আর
Fine,
আমার
fine.
আমাদের কোনো
বিনয়দাকে দিয়ে
ঝামেলা
দেবো,
থাকবে না।
আর আমার বিলটা স্বপন দা আমি বিনয়দাকে দিয়ে দেবো। তারপরে
স্যার, অনেকে জিপে তে বেশি কমফোর্টেবল, জিপের কি ডকুমেন্টস থাকে না, মানে যে স্ন্যাপশটটা যেটা পাঠানো ওটা কি ডকুমেন্টস নয়?
না, কার এগেইনস্টে পাঠাচ্ছি।
হ্যাঁ
যে একটা টাকা পাঠাচ্ছি
yes right
তো তার একটা এগেনস্টে পাঠাতে হবে, এই টাকার
হ্যাঁ
এগেনস্টে আমি টাকাটা পাঠাতাম, সেই
হ্যাঁ
রোহিতদা যেটা কিনেছে তার একটা ইনভয়েস বেরোয়।
হ্যাঁ ঠিক কথা। না না, যাদেরকে
invoice-টা-
প্রাইজ মানিটা দিচ্ছি ধরুন, যে সমস্ত
মানে
না,
গুগল
ক্যান্ডিডেট,
পেতেও থাকে,
fact নয়,
হ্যাঁ,
গুগল
price money
পেতেও
টা fact
থাকে।
নয়।
প্রাইজ
এনইএফটি
মানিটা
দিয়ে দাও,
আমাদের
এনইএফটি দিলে যেটা হবে না সেটা হচ্ছে
হ্যাঁ
আমাদের এটা করতে খুব সুবিধা হয়ে যায়, কারণ আমাদের ওয়েস্ট বেঙ্গলে তো গুগল পে নেই, ওটা তো সোমনাথ দার পার্সোনাল হয়ে গেল।
ওকে
আমি
ওকে
সেই জন্যই এনইএফটি করতে
ওয়েস্ট
চাই।
বেঙ্গল
ঠিক আছে,
একাডেমি অফ
হ্যাঁ আই গট ইউর
পিডিয়াট্রিক্স
পয়েন্ট স্যার, আই গট ইউর পয়েন্ট স্যার, আই গট ইউর পয়েন্ট। ঠিক আছে, বলে দিচ্ছি।
আমি ওই জন্য চাইছি যে তিনজন মানে ফার্স্ট সেকেন্ড থার্ড যাদের পেমেন্টটা করা হবে,
হুম
প্রাইজ মানিটা, তাদের নাম আর তাদের ব্যাংক ডিটেলসটা আমাকে দিলে আমি তাদের
হুম
নাম
হুম,
গুগল পে করে দেবো, আর আমি ভাউচারে লিখে দেবো যে দিস অ্যামাউন্ট গোস টু ফার্স্ট প্রাইজ অফ
ঠিক আছে
দিস
ঠিক
এন্ড
আছে,
সেকেন্ড।
তাহলে ফার্স্ট সেকেন্ড থার্ডের জিপে নাম্বার নিয়ে নিই, আর রোহিতেরটায় ক্যান্সেল চেক নিয়ে নিই, সেটাই সুবিধা, তাই তো?
ক্যান্সেল চেক না, ও এনইএফটি জানিয়ে দিক না তোমাকে, আমরা পাঠিয়ে দেবো,
ওকে ঠিক আছে,
আমরা এনইএফটি করে দেবো, সবাইকে এনইএফটি করে দেবো।
ঠিক আছে
আমার
ফাইন,
ডকুমেন্টেড হয়ে যাবে।
ঠিক আছে ফাইন, দ্যাটস ফাইন।
স্বপনদা লাস্ট একটা কথা, অগ্নি পরীক্ষায় উত্তীর্ণ হয়েছি।
হ্যাঁ হ্যাঁ ঠিক আছে, একদম বললাম তো, বললাম তো।
ওটা পার্সোনালি কথা হবে।
সুমন্ত্র,
Yes, sir.
একে তুমি রোহিতকে বলে দাও যে আমি
হ্যাঁ হ্যাঁ
বলবো যে যাতে আমাদের ওয়েব একটা আমি
হ্যাঁ হ্যাঁ, এখনই স্যার ফোন করে নিচ্ছি, এটা বন্ধ হলে আমি ফোনটা করে নেবো একবার। ওকে ভালো